गणनायका सर्वविघ्ननाशका सकलविद्यादायका निष्कलंका निर्विकल्पा नित्यसत्यादायका एकदंता वक्रतुंडा गणपते लंबोदरा जय गणेश जय गणेश जय जय गणनायका सर्वविघ्ननाशका सकलविद्यादायका जय गणेश जय गणेश जय जय गणनायका सर्वविघ्ननाशका सकलविद्यादायका. Thank you.
Thank you, Arunya. My forensic professor used to tell us the only specialty where the patient approaches a doctor with smile is obstetrics, that is pregnancy. But sometimes rarely the happy moment may be disturbed because of PRACI, and which is a nightmare for the obstetrician, treating physician, intensivist, and not the least is nephrologist, on whom the ultimate burden falls. And now we will start the academic feast on PRACI with renowned nephrologists across the state and important figures in nephrology as the moderators. And we will start our program with opening remarks by my guru, Dr. P.N. Jikki Madam. Over to Jikki Madam.
Thank you, Dr. Saivani. So, good morning to every one of you, especially my pranams to my teacher, Dr. Anuradha, and my other colleagues and dear friends. After the festivities of Dasara and Diwali, now you are invited to join this webinar symposium on pregnancy-related acute kidney injury, which is organized by the WIN-AP chapter. And this pregnancy-related acute kidney injury is peculiar to women only, and that's why we thought we should have it in WIN-AP. And this has proved to be largely preventable worldwide, as the incidence, which was around nearly 20% of all the acute kidney injury 3 decades back, has dwindled to nearly 6 to 8% in most developing countries and nearly 0 to 3% in developed countries. But of late, there is a small, slightly increased incidence in the developed nations due to the increasing maternal age, and who have comorbid conditions like diabetes, hypertension, which predisposes them to acute kidney injury. I invite all the young, enthusiastic speakers to talk on the new insights in the pathophysiology of pregnancy-related acute kidney injury and the impact on the management. And over to Saivani to conduct the webinar. Saivani?
Saivani. Good morning, madam. Actually, for the first session, physiology of pregnancy and pathophysiology of PRACI, Dr. Hitaishi madam should be the moderator, but madam has an important work, so she couldn't attend. And Hitaishi madam did MBBS MD from SV Medical College, Tirupati, and she did DM DNB on nephrology in Usmania Medical College, and she is a consultant nephrologist at Manasa Kidney Foundation, Tirupati, since she is practicing in Manasa Kidney Foundation since 2002. And the speaker for the session is Sindhu Chaganti. She is a very enthusiastic speaker. She voluntarily accepted for the talk, and she is an assistant professor in Pinnamaneni Siddhartha Medical College, and she did her DM from SRMC. And I request Sindhu Chaganti to start the session.
Am I audible, ma'am?
Yes.
And
yes.
Good morning, everyone. I hope my slides are moving.
Yes, ma'am, they are moving. Please go ahead.
Yes,
Okay.
go ahead.
Good morning, everyone. I'm Dr. Sindhu. Thank you for this opportunity to present physiology and pathophysiology of pregnancy AKI in WIN India, WIN AP chapter.
Rahul?
First, I'll start first with the physiology of pregnancy, hemodynamic and vascular changes, and renal adaptations in pregnancy, followed by pathophysiology of pregnancy AKI. Coming to the physiology of pregnancy, early in pregnancy, as early as 6 weeks of gestation, prior to the establishment of uteroplacental circulation, systemic vascular resistance decreases and arterial compliance increases. This decrease in systemic vascular resistance directly leads to several other cardiovascular changes, like blood pressure falls by an average of 10 millimeter mercury, reaching its lowest point at 18 to 24 weeks of gestation. And as seen in the figure, the mean arterial pressure falls around 18 to 24 weeks of gestation and almost normalizes at the end of the gestation. And sympathetic activity is also increased, reflected in a 15 to 20% increase in heart rate. The combination of increased heart rate and decreased afterload leads to an increase in cardiac output in the early first trimester, which peaks at 50% above the pre-pregnancy levels. In this picture depicts, the green line depicts the heart rate, increase in heart rate throughout the pregnancy by about 15 to 20%, and stroke volume by about 30% by the end of the third trimester, and above the pre-pregnancy levels by the end of third trimester. And also, estrogen increases angiotensinogen synthesis by the liver. Aldosterone and deoxycorticosterone from progesterone conversion increases the sodium retention. So increased salt and water retention increases the plasma volume. There will be net excess of water resulting in decreased osmolality. A lower threshold of osmoreceptors, a low set point for osmotic set point for ADH release, which in turn causes water gain, reduces the oncotic pressure, and intensifies the increase in glomerular filtration rate. Total body water also increases by 6 to 8 liters, leading to plasma volume interstitial volume expansion. And thus, most women have clinical edema at some point during pregnancy. There is also cumulative retention of about 950 millimoles of sodium distributed between maternal extracellular compartments and the fetus. The plasma volume increases out of proportion to red cell mass, leading to mild physiological anemia. Hemodynamic parameters changes in pregnancy. Plasma volume increases by 30 to 50% above the baseline. Blood pressure dips by almost 10 millimeter mercury, reaching its nadir by 18 to 24 weeks. And cardiac output increases by about 50%. Heart rate increases by 15 to 20 beats per minute. Renal blood flow increases by 80% above the baseline, and GFR increases to 40 to 50% above the baseline. Coming to the renal adaptations to pregnancy, pregnancy differs fundamentally from other comorbid conditions of peripheral vasodilatation, such as sepsis, cirrhosis, and high output congestive cardiac failure, all of which are characterized by peripheral vasodilatation and renal vasoconstriction. But in pregnancy, there will be peripheral vasodilatation as well as renal vasodilatation. This suggests that there is specific renal vasodilating effect in pregnancy that overrides the constriction by factors such as RAS. And they found that the animal models from rats were done, and recent advances have shown this hormone called relaxin, produced by decidua, placenta, and corpus luteum in the first early stages of pregnancy. It activates the relaxin receptors to exert both rapid and sustained vasodilatation, renal vasodilatation, leading to increased endothelial nitric oxide availability, causing renal vasodilation. So this finally leads to generalized renal vasodilation, decreased afferent and efferent arteriolar resistance, and subsequent increase in renal blood flow by about 80% and glomerular filtration rate. GFR increases by about 40% within weeks of conception, and it is maintained at this level until delivery. In early pregnancy, this is primarily mediated by an increase in the renal plasma flow. In the second half of the pregnancy, renal plasma flow declines towards pre-pregnancy levels, yet GFR remains high, reflecting relatively increased filtration fraction. Because of already mentioned decreased capillary oncotic pressure and increased filtration coefficient, the GFR remains high. The increase in GFR results in a physiological decrease in serum creatinine, serum urea, and uric acid levels. Normal creatinine clearance in pregnancy raises to 150 to 200 milliliter per minute, and average creatinine falls from 0.8 mg per dl to 0.5 to 0.6 milligrams per deciliter. Hence, a serum creatinine of 1.0, which would be considered as a normal in a non-pregnant individual, reflects an impairment in renal function in pregnant women. Similarly, urea, measured as blood urea nitrogen, falls from an average of 13 milligrams per deciliter in non-pregnant state to approximately 8 to 10 milligrams per deciliter in pregnancy. And urinary protein excretion rises in normal pregnancy from the non-pregnant level of about 100 milligrams per day to 180 to 200 milligrams per day in the third trimester, and occasionally it can go up to 300 milligrams per day prior to the delivery. In women carrying multiple gestations, physiological proteinuria is even greater, with almost half of the women excreting more than 300 milligrams per day. This may result in a false positive urine dipstick for protein, testing for protein, particularly on a concentrated urinary sample. Like I mentioned, serum uric acid declines early in the pregnancy because of the rise in GFR, reaching a nadir of 2 to 3 milligrams per deciliter by 22 to 24 weeks. Therefore, thereafter the uric acid levels begin to rise, reaching non-pregnant levels by term. The late gestational uric acid levels increase is attributed to increased renal tubular absorption of urate. Pregnancy is also characterized by several changes in renal tubular function due to large increase in tubular balance. GFR, glomerular tubular balance, requires a concomitant rise in tubular solute reabsorption in order to avoid excessive renal losses, and kidney achieves this balance flawlessly, and sodium balance is maintained normally. Pregnant women have normal excretion of exogenous solute load and appropriately conserve sodium when intake is restricted. The ability to excrete a water load is also normally maintained, although at a lower osmotic set point. Osmotic threshold for stimulation of both ADH and release and thirst is decreased by a mechanism that appears to be maintained by HCG and relaxin. This results in mild hyponatremia. The serum sodium typically falls by 4 to 5 millimoles per liter below the non-pregnancy levels. Animal studies suggest that this is because of the increased aquaporin 2 channels in the collecting tubule, and this might contribute to this effect. Mild glycosuria and amino aciduria can occur in normal pregnancy. This occurs in the absence of hyperglycemia or renal disease. These are thought to be due to combination of increased filtered glucose load and less efficient tubular reabsorption. Coming to the anatomical changes that happen in pregnancy, kidney length increases by about 1 to 1.5 centimeters and volume increases up to 30%. Physiological dilatation of urinary collecting system is seen in approximately 50% of pregnant women more frequently on the right than the left. The physiological hydronephrosis in pregnancy is mainly explained by anatomic compressive factors. Right ureter crosses pelvis and iliac vessels in more acute angle than the left. So right hydronephrosis is more common than the left. Progesterone also reduces the ureteral tone and may contribute to hydronephrosis of pregnancy. So this ultrasound image shows the physiological hydronephrosis. Although it is a normal state, it is worth noting that urinary stasis can increase the risk of pyelonephritis. Thus, importance of detecting and treating asymptomatic bacteriuria in pregnancy. So this table summarizes the whole physiological changes in pregnancy, as I mentioned already. Coming to the serum chemistry and hematological changes, hemoglobin decreases by an average of 2 grams per liter. Creatinine decreases to 0.4 to 0.5 grams per liter. Uric acid reaches a nadir of 2 to 3 by 22 to 24 weeks, and then increases back to the pre-pregnancy levels by term. Sodium decreases by 4 to 5 milliequivalent per liter, and there will be a new osmotic set point of approximately 270 milliosmoles per kg. That is about the physiology of pregnancy. Coming to the pregnancy AKI, the impact of pregnancy AKI. Pregnancy-related AKI is a global health problem. It carries a higher risk of both maternal and fetal morbidity and mortality. 14-fold higher likelihood of inpatient mortality and 10-fold higher risk of future cardiovascular events. Risk of chronic kidney disease and kidney failure, and the risk of adverse fetal outcomes of preterm births, low birth weights, and perinatal mortality. This is a recent hypothesis establishing a link between pregnancy AKI and neurocognitive impairment. In the setting of pregnancy-related AKI, there is an increase of circulating inflammatory mediators and oxidative stress, which damages the blood-brain barrier, allows for neurotransmission to take place eventually, contributing to neurocognitive impairment. So this is the impact of pregnancy AKI. Moving on to the etiologies of pregnancy AKI, various etiologies depending upon the trimester. In the first trimester, the common causes of pregnancy AKI could be secondary to hyperemesis gravidarum and septic abortions, especially in the developing countries. And second and third trimesters, obstruction, acute fatty liver of pregnancy, and most commonly preeclampsia, eclampsia, and HELLP syndrome, TMAs, glomerulonephritis, UTIs, and pyelonephritis. Coming to the postpartum, sepsis, atypical HUS, NSAIDs, all and hemorrhages, both antepartum and postpartum. So depending upon the etiology, depending upon the trimester, etiology of pregnancy AKI varies. Coming to the other causes of pregnancy AKI like peripheral sepsis, amniotic fluid embolism, and CKD unrecognized. And etiology of pregnancy AKI can also be divided into whether they are pregnancy specific and non-pregnancy specific. Pregnancy specific causes include preeclampsia and HELLP, TMA, acute fatty liver of pregnancy, sepsis, hemorrhage, septic abortions, and hyperemesis in the first trimesters. And non-pregnancy specific causes of pregnancy AKI include pre-renal causes like hypovolemia, hypotension, renal causes like glomerulonephritis or lupus nephritis, most commonly lupus nephritis and its flares, tubular necrosis, interstitial diseases, vasculitis, obstructions, stones, and malignancies. Coming to the developing nations, the most commonly seen pregnancy AKIs, causes of pregnancy AKI in developing countries are hypovolemia, septic abortions, hemorrhages, pyelonephritis, acute cortical necrosis, and injury to ureter or bladders during C-section. In the developed nations, whereas in the developed nations, the etiologies of AKI specific to pregnancy include HELLP, TMA, preeclampsia, pyelonephritis, acute fatty liver of pregnancy, and DIC secondary to amniotic fluid embolism, sepsis. Coming to the, now I'll discuss about the pathophysiology, more of pregnancy specific causes of AKI. The first one and most common one being preeclampsia and HELLP. The placenta and specifically impaired placentation play a key role in the pathogenesis of preeclampsia. Two-stage model of pathophysiology for preeclampsia was proposed. In the stage 1, there is a deficient uterine arteries, spiral artery remodeling leading to placental ischemia. So this picture, the top one, shows the normal. What happens in normal pregnancy are these white cells are cytotrophoblasts. They come from the chorionic villi. They invade the maternal spiral arteries and they transform themselves into endothelial cells. This is called pseudo-vasculogenesis or vascular mimicry. And by transforming themselves into endothelial cells, they make the high resistance, low flow, low capacitance vessels of maternal endothelium into high capacitance and low resistance, so that the blood supply of the placenta will not be compromised. But in the picture down, the picture with the preeclampsia, what happens is this transformation is lost. This pseudo-vasculogenesis or vascular mimicry is impaired. So the maternal vessels, they remain as high resistance and low capacitance, leading to hypoxia, leading to decreased blood supply to the placenta. And stage 2 is the consequent release of anti-angiogenic factors like soluble FMS like tyrosine kinase 1, SFLT1, or soluble vascular endothelial growth factor receptor 1, soluble endoglin. All of these leads to generalized endothelial dysfunction. So what happens is all these factors, endothelial factors, they in normal pregnancy, VEGF and PIGF, they are required for normal health of maternal endothelium. In preeclampsia, this excess SFLT1 binds to the circulating VEGF and PIGF, and it will inhibit these VEGF and PIGF to bind to its own receptors, and thus impairing normal signaling of both VEGF and PIGF through their cell surface receptors. So this excess SFLT1 and other factors, they lead to maternal endothelial dysfunction. And immunological and environmental factors, apart from these endothelial factors, they together with genetic predisposition may contribute to preeclampsia. Diverse immunological abnormalities have been described, from agonistic antibodies to angiotensin 1 receptors to immunological abnormalities similar to those of organ rejection. So all these combinedly, genetic factors, oxidative stress, other factors like all these endothelial factors, all these leads to growth restriction in the fetus and hypertension, proteinuria, other complications like liver dysfunction and cerebral edema in the maternal. Angiotensin 1 receptor agonistic autoantibodies, they increase the oxidative stress and secretion of endothelin 1, a potent vasoconstrictor contributing to hypertension seen in preeclampsia. And the resultant endothelial dysfunction causes this PAS imaging showing cell ballooning with consequent capillary obstruction with glomerular endotheliosis. The glomerulus appears in this PAS picture as a bloodless glomerulus. Mesangiolisis and the EM picture, figure B, it shows the glomerulus from the same patient, occlusion of the lumen cytoplasm and expansion of the subendothelial space with some electron dense material. So this is what happens in preeclampsia. Coming to the HELP, hemolysis, elevated liver enzymes and low platelet count, it is considered as a severe form of preeclampsia and it has higher maternal morbidity and mortality. Around 50% of women with HELP develop AKI, and AKI is associated with higher maternal mortality. This picture is a kidney biopsy image from a HELP patient, which was performed due to acute kidney injury, and it shows acute tubular necrosis with hemoglobin CAS. So that is about the preeclampsia and HELP. Coming to the TMA, thrombotic microangiopathies, gestation itself is a procoagulant state and a trigger for complement activation as for preeclampsia and HELP, and that which causes endothelial cell injury. TTP, It may be triggered by pregnancy in patients with congenital ADAMTS13 deficiency or acquired ADAMTS13 antibodies. Atypical HUS may be triggered by pregnancy in persons with complement dysregulation resulting from genetic or acquired causes, and especially in the postpartum period, atypical HUS, when inflammation, hemorrhage, and circulating fetal cells activate the alternate complement pathway. Coming to the acute fatty liver of pregnancy, it shares the features with preeclampsia, with severe features or HELP syndrome. It may be caused by fetal deficiency of mitochondrial beta oxidation of fatty acids, and it leads to accumulation of free fatty acids and intermediate products of metabolism that crosses the placenta and causes fatty deposits in liver and kidney, and leading to AKI. Overall, these entities cause AKI through different mechanisms like direct effects on the kidney, pre-renal AKI due to hemorrhage, hypovolemia or edema, ATN or acute cortical necrosis that increases perinatal mortality by about 3-fold and may lead to CKD. Coming to the last entity, acute cortical necrosis, it results from severe hypotension. It is a pathological diagnosis based on the presence of diffuse or patchy cortical necrosis on renal biopsy with intravascular thrombosis in the interlobular or afferent arterioles while sparing the medulla. Highly morbid, this acute cortical necrosis usually leads to permanent kidney failure. The reasons why acute cortical necrosis occur in association with pregnancy are unclear. One proposed mechanism is that pregnancy is a hypercoagulable state with increased levels of coagulation factors in the face of repressed fibrinolytic system. If an additional trigger is present on the top of it, then a series of complex and self-perpetuating vasomotor and humoral phenomenon follow, such as coagulation, renin-angiotensin, and complement pathways will be activated, leading to acute cortical necrosis. Coming to the Indian data about various etiologies of pregnancy AKI, it was published recently in September 22 in JAPI by Dr. Manisha Sahai ma'am, who also happened to be one of the moderators of today's session. And the title of this article is Pregnancy-Related AKI in Public Hospital in South India, Changing Trends. Previously, it was thought that septic abortions and hyperemesis, septic abortions and sepsis was the most common cause of AKI, pregnancy AKI in developing countries like India. But this South Indian data, which they have taken almost 395 patients with a mean age of 27 plus or minus 3 years, they found that almost 44%, that is the majority of the patients, had preeclampsia as a cause of pregnancy AKI, followed by puerperal sepsis and antepartum or postpartum hemorrhage. Renal biopsy was performed in 103 patients, and they found that 50% had cortical necrosis, whether 25% of them had a diffuse and 25% had a patchy cortical necrosis, while 20% had ATN. About 76% of these patients required dialysis, and 76% improved, and 8.3% of the patients progressed to end-stage renal disease. So ending today's talk, kidney placental crosstalk. Placenta and kidney are two metabolically active organs that during pregnancy have a complex relationship with the aim of maintaining homeostasis. And given this bidirectional nature, acute or chronic dysfunction of one can lead to compromise of the other. An imbalance between angiogenic and anti-angiogenic factors in the placentation disorders such as preeclampsia, HELP, results in hypertension that may cause acute kidney injury. In contrast, prior kidney injury increases the risk of placentation and adverse maternal and fetal outcomes. Understanding this bidirectional potential for compromise from placenta to kidney and vice versa provides a better framework to limit the damage to both organs and improve maternal and fetal outcomes. Thank you. These are my references.
Dr. Saivani, can you take over? Am I audible, Dr. Sindhu?
Yeah. Thank you, Sindhu, for your excellent and lucid presentation. And question and answer session will be at the end of all 4 presentations. Next, we will move on to next session, evaluation of Praki by Pavani Madam. And the moderator for this session is Dr. Manisha Sahai Madam, my teacher and mentor, who doesn't need any introduction and who has who has done very much work, and even you have reported the madam's work in the field of Praki. And Madam is a vice president of WIN, and she has so many roles in International Society of Nephrology, and she is editor in chief in organ transplantation nephrology journal, and she had many publications, and she had trained many nephrologists under her in Usmania General Hospital like me. And over to you, Madam, to introduce the speaker.
Thank you, Dr. Saivani, for that kind introduction. And I would like to congratulate the AP chapter of WIN for doing such a great job. The chapter is very dynamic and vibrant and full of brilliant, beautiful lady nephrologists. So my hats off to all of you. And thank you, Dr. Sindhu, for the nice presentation. Now coming to Dr. Pavani, who's the next presenter. She has done her MBBS from SV Medical College, Tirupati, Andhra Pradesh. And she also did her MD in pediatrics. She is a pediatrician. She's done her post-graduation in pediatrics from the same institute. That's SV Medical College, Tirupati. She did her DM in nephrology from the Narayana Medical College, Nellore. And subsequently, she also underwent special training in pediatric nephrology in St. John's Medical College, followed by another special training in transplant at the prestigious IKDRC Ahmedabad. And I was amazed to find out that she is very interested in research project management, data analysis, and she's having a special interest in electronic medical records as well, which is my passion as well. And she has been a regular teacher, and her strength is she tries to be a perfectionist. So good to know, Pavani. And she learns, she likes listening to music. She plays chess as well and watches movies. So over to you, Dr. Pavani. You seem to be multi-talented, and I'm looking forward to your talk. Over to you.
Thank you very much, Manisha ma'am, for your nice introduction. Very kind of you. And Dr. Saivani, can I request the share of my presentation? I have shared in the group already.
Okay.
So Dr. Pavani will be
Bashir,
talking
are you
about
available?
the workup of Praki. So
Yes,
the etiology and workup, that's great. That's a very interesting and practical topic. So can you share the slides, Saivani?
Bashir, I request you to share the slide, the second PPT. Bashir, are you available?
Recording in progress.
So till they put up the slides, I mean, this is an important topic for all the postgraduates as well, because so many new things are happening. The etiology of Praki is very important because prognosis depends on that, the treatment depends on that, and a variety of investigations are available as well. So we should be able to pick up which Praki deserves a lot of investigations and which one does not. Over to you, Dr. Pavani. Slides are there.
The slides are visible, ma'am?
Yes, please go ahead.
Yeah, thank you, ma'am. I'll start with a brief introduction of evaluation of Praki. It was already discussed by Dr. Sindhu. Praki is a heterogeneous disease entity due to various etiologies, which is an important obstetric complication. Because of these pathophysiological changes occurring in pregnancy and heterogeneity of symptoms, and sometimes overlapping of clinical and laboratory characteristics, the diagnosis and management of Praki is a complex challenge for the treating physician. So as Jiki ma'am already told, retrospective data from Canada and USA have shown a renewed increase in the incidence of Praki from 1.7 to 2.7 in Canada and 2.4 to 6.6 per 10,000 deliveries respectively in the last 2 decades. This recent increase is as a result of increase in number of high-risk hospital deliveries and advanced maternal age, and increased incidence of diabetes, hypertension, and assistant reproductive technologies and with multiple gestation and pre-existing CKD in the mother. This etiological aspect is, I'm very sorry for the repetition of the slides. These were already discussed by the Sindhu, so I don't want to talk on this. Coming to the diagnosis as in the general population, the criteria or the classifications were KDIGO, Rifle and Akin classifications. We already know, but just to refresh our knowledge, the KDIGO classification stage 1 is the increase of more than 0.3 milligrams of deciliter within the 48 hours or more than 1.5 to 1.9 fold increase of creatinine from the baseline is the risk criteria. Injury is the increase of creatinine of more than 2 to 2.9 times. And failure is more than 3 times from the baseline or increase in the creatinine or serum creatinine of more than 4 milligrams per deciliter or initiation of renal replacement therapy. In patients of less than 18 years, the decrease in eGFR of to less than 35 ml per minute per 1.73 square meter body surface area. The Rifle classification and Akin classification are based on the increase in the creatinine and also decrease in the GFR. In Rifle, stage 1 is the 1.5 times increase of baseline creatinine or more than 25% decline in the GFR. In stage 2, injury, 2 times increase from the baseline creatinine and 50% reduction in the GFR. In failure, 3 times increase in the baseline of from the baseline creatinine or creatinine of more than 4 milligrams per deciliter, or any acute rise of creatinine of more than 0.5 milligrams or decline of GFR of more than 75%. In Akin, also there is GFR and urine output criteria is also there. These are already known for us, but none of these criteria are standard in pregnancy, and these are all not validated in pregnancy. As Sindhu already told, GFR increases by 40 to 60% due to hyperfiltration, vasodilatation, and increase in the effective plasma flow. So whenever the creatinine is around 0.8 itself is indicative of the acute kidney injury, which makes the diagnosis is challenging. When compared to the baseline, comparison of the baseline values is also not possible as renal function parameters are not obtained in pregnancy until injury is clinically suspected. And pregnant women may have a 30 to 40% reduction in the GFR without any significant increase in the serum creatinine, which makes further the difficulty in the diagnosis of the PACI. After thorough history taking and thorough physical examination and the need to review the medications the patient is taking, and the basic investigations along with the blood urea, serum creatinine, and the uric acid levels and the serum electrolytes, the complete urine analysis must be performed, including urine microscopy to see for any activity of the urine sediment if we suspect any glomerulonephritis, if we suspect any urinary tract infection or pyelonephritis, urine culture and sensitivity. And we need to quantitate the urinary protein either by 24-hour urinary collection or spot urine protein creatinine ratio. And in the blood picture, hemoglobin and the platelet count to be measured to rule out any thrombocytopenia, which is a common feature in the pregnancy-related acute kidney injury, and the peripheral smear to rule out microangiopathic hemolytic anemia. On the complete liver function test with the serum bilirubin, direct and indirect SGOT, SGPT levels, which were increased in HELP syndrome, serum haptoglobin levels, and the LDH to rule out hemolysis. Whenever we are suspecting obstructive causes or any renal calculi, ultrasound abdomen need to be done to rule out pathological hydronephrosis. In suspicion of connective tissue disorders, serological workup like anti-nuclear antibodies, anti-neutrophilic cytoplasmic antibodies, and the complement levels need to be done whenever there is suspicion of lupus nephritis, and along with the ADAM TS13 levels, which were decreased in the pregnancy-associated thrombotic microangiopathies. Is it audible, ma'am? Hello?
It is audible, ma'am.
Yeah, thank you.
Please go ahead.
Just to confirm. Coming to the various biomarkers that were in present, which are used in acute kidney injury, but not in the clinical usage. These are various circulating and urinary biomarkers for clinical use like neutrophil gelatinase associated lipocalin, liver type fatty acid binding protein, and the kidney injury molecule 1, cystatin C. These are also not validated in the pregnancy, and there is a need for the ideal biomarker other than serum creatinine, which is independent of the body weight, muscle mass, or other pregnancy-related changes. There is no such biomarker as of now. And now I am going to discuss few aspects of the pregnancy-related acute kidney injury pertaining to the diagnosis of these syndromes. The first one already discussed, the most common cause of the trend is now shifted from the sepsis, acute cortical necrosis to the preeclampsia, HELLP syndrome became the major cause of acute kidney injury in the pregnancy, even in developing countries. The incidence is around 2 to 8%, which is likely to increase as a result of advanced maternal age and increased assisted reproductive technologies and increased incidence of diabetes, hypertension, and elderly age of the mothers. Is the important cause of the AKI, and it is one of the most common complication of the pregnancy, which occurs predominantly in the second and third trimester of pregnancy, but in 5% of cases, it can also occur in the postpartum period. This ACOG criteria, diagnostic criteria of preeclampsia, which includes the criteria for the blood pressure and the proteinuria, the systolic blood pressure of 140 millimeters of mercury or more, or diastolic blood pressure of more than 90, which was measured on 2 occasions at least 4 hours apart after 20 weeks of gestation in a woman with a previously normal blood pressure. If there is systolic blood pressure of more than 160 or diastolic blood pressure of 110 or more, this severe hypertension, this is classified as severe preeclampsia. This need to be confirmed within a short interval, because within minutes is enough because to facilitate the timely antihypertensive therapy, unnecessary not delaying the treatment. Coming to the criteria of proteinuria, the protein expression should be more than 300 milligrams or more per 24-hour urinary collection, or protein creatinine ratio of more than 0.3 milligrams per deciliter or more, or if these things are not available, dipstick reading of 2+ can be taken as a criteria for proteinuria. Previously, proteinuria was given much importance, but even though now if there is no proteinuria also, the following, one of the following criteria is there, then it should be diagnosed as preeclampsia. Presence of thrombocytopenia with platelet count of less than 1 lakh per cubic mm, and renal insufficiency with serum creatinine concentration of more than 1.1 milligrams per deciliter, or doubling of serum creatinine concentration in the absence of other renal disease, and impaired renal function either in form of elevated blood concentration of liver transaminases to twice their normal concentration, presence of pulmonary edema, a new onset headache which is unresponsive to the medication and cannot be accounted by alternative diagnosis, or presence of visual symptoms. Even though when there is no proteinuria, presence of hypertension and with one of these criteria is itself enough for diagnosing the preeclampsia. Preeclampsia with severe features, all the target organ dysfunction features are similar. The blood pressure criteria will increase. The systolic blood pressure of more than 160 and diastolic blood pressure of more than 110 will classify it as severe preeclampsia. Preeclampsia is said to be superimposed when it occurs in a woman with chronic hypertension. Whenever there is in a already previously known hypertensive mother, there is worsening or resistant hypertension which occurs acutely, or any new onset proteinuria, or if any existing proteinuria, there is sudden increase in the proteinuria or significant new end organ dysfunction which occurs after 20 weeks of gestation. It is considered as preeclampsia in a mother with chronic hypertension. If systolic blood pressure is more than 160 and diastolic more than 110, confirmation within minutes is sufficient to unnecessarily avoiding the delay for the starting antihypertensive therapy. Coming to the HELLP syndrome, up to 20% of the women with severe preeclampsia develop HELLP syndrome, which can be diagnosed with serum LDH levels of more than 600 units per liter, AST and ALT levels more than twice the normal, with thrombocytopenia of less than 1 lakh per cubic mm. And few insights into the measurement of this angiogenic factors and anti-angiogenic factors, but these are not for the usage in our country. These are used in certain countries. These are commercially available. Determination of the urinary or plasma anti-angiogenic factors and angiogenic factors like SFLT1 and placental growth factor, it can be done to differentiate preeclampsia from other clinical pictures which are mimicking like preeclampsia. These tests are available in certain countries, but in United States also these are not available. These are available in Germany and UK. They suggested the use of 4 tests. They are Delphia Express Placental Growth Factor 1, 2, 3, Delphia Express SFLT and Express Placental Growth Factor 1, 2, 3 ratios, Alexis Immunoassay, SFLT Placental Growth Factor ratio, and trials. Pardon, ma'am?
I request all the others to mute themselves. Pavani, you are clear. Please go ahead.
Okay, ma'am. Thank you. Trials placental growth factor tests. These tests have more of negative predictive value. If these are negative, then we can exclude the preeclampsia and we can think of alternative diagnosis. Or if these tests are increased, then we can take care of the mother and we can start on the prophylactic therapy. As there is no specific treatment for the preeclampsia, if these are available, they can be used. But the International Society for the Study of Hypertension in Pregnancy states that assessment of these factors to be done only if they are available, and if present, reduced placental growth factor to less than 5th percentile of normal, or increased ratio of SFLT and placental growth factor of more than 38 by Roche assay, it strengthens the clinical diagnosis, but it cannot be used as sole criteria for diagnosing the preeclampsia. But the ACOG and Society of Maternal Fetal Medicine are not recommending to do these tests as of now. Coming to the second topic that mimics the preeclampsia HELP syndrome, I'll brief about this because the following speakers will in detail, they'll tell the topics, and I'll brief about only diagnostic aspects of thrombotic microangiopathies. Pregnancy-associated thrombotic microangiopathies are rare, which affects the 1.25,000 pregnancies. They are defined by the presence of fibrin platelet microthrombi in the microcirculation of multiple organs. Depending on the most affected organ, either it can be TTP, which is as a result of the ADAMTS13 deficiency, which can cause von Willebrand factor multimer agglutination in the blood vessels, and the hemolytic uremic syndrome or complemented mediated thrombotic microangiopathy, which is as a result of the uncontrolled activation of the alternate complement pathway. In pregnancy-related thrombotic microangiopathies, renal involvement is very common, and AKI is present in two-thirds of cases. Most patients have severe renal failure requiring dialysis therapy, which AKI results from renal thrombotic microangiopathy. And the long-term renal outcome is also very poor. 76% of the patients with AKI related to pregnancy TMA develops end-stage renal disease. And pathologically, this TMA is characterized by the multiple intraluminal thrombi with double contour appearance of capillary basement membrane and mesangiolisis, and with arterial and arteriolar changes, including mucoid intimal thickening and fibrinoid necrosis or thrombosis. Coming to the features of thrombotic thrombocytopenic purpura is characterized by the fever with severe thrombocytopenia and microangiopathic hemolytic anemia. The renal involvement in TTP is less severe with creatinine values of less than 1.4 milligrams per deciliter. The neurological symptoms in form of disorientation, ataxia, headache, focal changes, seizures or aphasia are more common in TTP. And HUS renal involvement is more pronounced compared to the TTP, with a creatinine of usually more than 2.3, and the presence of neurological symptoms are rare. This pregnancy TMA may occur anytime during the pregnancy. With the timing of onset of TMS, we can differentiate the two. TTP is usually diagnosed in the late part of the second and third trimester, where there is a physiological reduction of the ADAMTS13 levels. So the values of ADAMTS13 deficiency will be more pronounced, and the symptoms are more pronounced in the late second and third trimester in TTP. Atypical HUS usually occurs in the postpartum period. It can occur in the first 6 months after delivery, which accounts the pregnancy-induced thrombotic microangiopathies account for maternal mortality of 10 to 30% and with high rates of perinatal mortality rate also. And we should differentiate the preeclampsia HELP and the pregnancy-associated TTP HUS. The few differences are the coagulation abnormalities like elevated antithrombin levels, elevated D dimers, high fibrinogen levels are absent in TTP HUS, but they are common in the HELP. Isolated LDH is usually seen in the HUS TTP without any rise in the hepatic transaminases. The rise of hepatic transaminases strongly suspects the HELP syndrome. Another entity which is also mimicking the preeclampsia HELP and the thrombotic microangiopathies, and usually in the timeline also this is similar, is the acute fatty liver of pregnancy. It is an obstetric emergency which can lead to permanent liver failure with the incidence of 1 per 7,000 to 1 per 20,000, resulting from an autosomal recessive genetic error which causes a defect in the long chain 3-hydroxy acyl-CoA dehydrogenase, an enzyme involved in the mitochondrial fatty acid beta oxidation, which results in excessive fetal fatty acid accumulation, which are released into the maternal circulation, which can cause fulminant hepatic dysfunction. The diagnosis of AFLP depends upon the clinical and the laboratory findings, but the definitive diagnosis is by the liver biopsy, where there were presence of lipid microvesicle without inflammation or necrosis is the characteristic feature of AFLP. which usually occurs in the third trimester of the pregnancy. And there is 50% of these patients have signs of preeclampsia or HELLP syndrome also. The early symptoms of the nausea, vomiting, and abdominal pain. Later, they can develop jaundice and encephalopathy. In severe cases, there can be DIC, severe thrombocytopenia, hypoglycemia, intra-abdominal hemorrhage, and also central diabetes insipidus. There is over 60% of pregnant women, they develop AKI in AFLP. In most women, there is complete liver and kidney recovery after delivery. These are the Swansea criteria for AFLP. Of these 15 criteria, at least 6 must be there for the diagnosis of the acute fatty liver of pregnancy. The criteria are vomiting, abdominal pain, polydipsia, polyuria, encephalopathy, elevated bilirubin of more than 0.8 milligrams per deciliter, hypoglycemia with sugar values of less than 72 milligrams per deciliter, uric acid levels of more than 5.7 milligrams per deciliter, leukocytosis with WBC count of more than 11,000 cells per cubic mm, presence of ascites or bright liver on ultrasound, elevated transaminases of more than 42 of SGOT and SGPT, elevated ammonia levels of more than 47 microliters, and the renal impairment with creatinine of more than 1.7 milligrams per deciliter, coagulopathy with altered PT and APTT, and the presence of microvesicular steatosis on liver biopsy. Of these criteria, at least 6 criteria must be there for the diagnosis of AFLP. And another important cause for the AKI, which can flare up or which can worsen the renal function is the lupus nephritis. It mimics the preeclampsia and thrombotic microangiopathy. So diagnosing lupus nephritis activity during pregnancy is a challenge. And we can do by the confirming the C3 and C4 levels which were decreased, and the increased rising titers of anti-dsDNA, anti-Smith antibodies, and SSA autoantibodies in presence of active urinary sediment or increased proteinuria or new onset of any skin rash may suggest the diagnosis. But the drop in the complement factor levels can be disguised because there is pathophysiologically, normal physiologically, there is increase in the complement levels as a result of increased production by the liver. So the complement levels sometimes may not help in diagnosing the lupus nephritis. This is a slide which depicts which are the common etiologies which are causing acute kidney injury in the later part of second and third trimester and in the postpartum period, which will have clinically and laboratory wise mimicking pictures, and the diagnosis of these entities is little bit difficult during pregnancy. These are preeclampsia, HELLP, TTP-HUS, AFLP, antiphospholipid antibody syndrome, and the lupus. The time point is one difference that we can assess. Preeclampsia HELLP usually occurs after 20 weeks of gestation. TTP-HUS usually occurs in the late part of second and third. Atypical HUS in the postpartum period. AFLP in the second and third. Antiphospholipid lupus can occur throughout the pregnancy. Neurological symptoms are more pronounced in the TTP. Fever is present usually in the TTP-HUS and atypical HUS, and the cystocytes are usually present, indicating microangiopathic hemolysis in preeclampsia, HELLP, and TTP. Thrombocytopenia is more pronounced in HUS TTP, and transaminase levels elevation is more pronounced in acute fatty liver of pregnancy. Hypoglycemia is also a prominent feature, which is a distinguishing feature for the acute fatty liver of pregnancy. Proteinuria is more common in the preeclampsia, HELLP, and also in TTP-HUS and in lupus nephritis. Decreased ADAM-TS13 levels are seen in TTP. The treatment is prompt delivery is helpful for preeclampsia, HELLP, and acute fatty liver of pregnancy, but not in others. In TTP-HUS, plasmapheresis is indicated. In atypical HUS, along with plasmapheresis, eculizumab is needed, and immunosuppressive therapy is needed for the lupus nephritis. Coming to the renal biopsy in pregnancy, the decision is quite challenging. It is made based on gestational age and available treatment options and the viability of pregnancy. It should be performed when the diagnosis can facilitate the management to improve the maternal and fetal outcomes. It is safe to biopsy in up to less than 25 weeks of gestation in the first and second trimesters. As the pregnancy approaches the third trimester, because of the viability of the fetus, clinical effort should be focused on the early delivery and biopsy to be done in the postpartum period. Coming to the rare causes of AKI, First trimester, the common cause is hyperemesis gravidarum, where there is severe and persistent vomitings, which can cause weight loss exceeding 5% of the pre-pregnancy weight. And there is ketonuria is also there. It is diagnosed with presence of dehydration and hypovolemia with hypokalemic metabolic alkalosis and mildly raised transaminases and increased hematocrit and mild hyperthyroidism as a result of the TSH activity of HCG. Another important cause, which is also most common and most dangerous obstetric emergency, is the peripartum bleeding, can occur as a result of miscarriage or atonic uterus, placenta previa, or disorders of the placental separation. Obstetric trauma injuries such as tearing of cervix or vagina, rupture uterus, or clotting disorders is the most dangerous complication. The clinical picture itself is with uncontrolled bleeding and persistent hypotension, and associated disorders of these renal microcirculation can cause either reversible or irreversible acute renal cortical necrosis. Another one is the obstruction of post-renal causes, as same in the general population. This obstruction-related kidney damage during pregnancy is a rare cause. The mechanical obstruction usually occurs in the second or third trimester because of the gravid uterus. And other renal calculi is also another common cause for the obstructive AKI. Coming to the rare causes of pregnancy AKI, this I'm briefly telling about this peripartum cardiomyopathy as a result of prerenal AKI and the milk alkali syndrome. Fulminant hepatitis as a result of hepatitis E is more common during pregnancy, and rhabdomyolysis, ruptured splenic artery aneurysm, sickle cell anemia, amniotic fluid embolism. These are all the rare causes of pregnancy AKI. So a better understanding of all these etiologies, different causes which causes renal function deterioration during pregnancy, the prompt diagnosis and prompt appropriate treatment of AKI could significantly improve the prognosis in the mother and the child, but which requires the multidisciplinary approach between the obstetrician, nephrologist, and the physician. Thank you very much for patient hearing.
Thank you, Pavani madam, for your nice elaboration on PRACI. Over to you, Manisha madam. Please comment on madam's lecture.
Yeah, so that was a great lecture, Pavni. You have covered most of the etiologies and the workup, and as you showed in the table, see, no investigation is specific, and the more we handle cases, we understand. So now the PRACI etiology is, like in developed world, moving towards preeclampsia in our country as well, and the puerperal sepsis is another important etiology. But we should make sure that we should not label everything as preeclampsia. We should look out for the differentiating features. For example, severe hypertension, not recovery within 3 to 5 days after delivery. They are the indicators of HUS, especially if thrombocytopenia is there and severe hypertension is there. So only my message is, we'll have the discussions at the end, but only thing is that always before you try to start any treatment, collect a sample, keep a sample for further evaluation later on, because sometimes Adam TS and all, we may not be thinking earlier and we may miss, but that's very rare in our setting. But anyhow, complement evaluations, keep the sample. So congratulations for a wonderful presentation. We'll have the discussions at the end, and I hand over to Saivani for the next lecture.
Thank you.
Next, we move on to management of PRACI. For this session, the moderator will be Anuradha madam. Anuradha madam is a teacher for all my teachers, Jikki madam and Manisha Sahai madam. She is the founder of nephrology department in Osmania Medical College. She did graduation and post-graduation from Osmania Medical College and nephrology training from CMC Vellore. And she is a retired professor, HOD of nephrology in Osmania Medical College, and she had teaching experience of more than 40 years and trained more than 25 postgraduates. Until now, she is teaching and she is very interested in academic activities. And she is the president of ISN in 2006 to 2007 and scientific committee member of both ISN and Southern chapter of nephrology. And she had given many guest lectures, trained many postgraduates, and presented many papers in national and international journals. Over to you, madam, to introduce the speaker, Ratnaprabha.
Thank you, Saivani. Good morning, everyone. I think pregnancy AKI or PRACI is of special interest to me, because as women, I think we are more focused on the problems related to women. And I should congratulate the WIN AP for organizing this webinar, which is an exclusive problem for women. Next, going on to our next topic, which is going to be dealt by Dr. Ratna Prabha. I have great pleasure in introducing Dr. Ratna Prabha, who is presently an assistant professor of nephrology at the Andhra Medical College, Visakhapatnam. She completed her MBBS and MD from Rangaraya Medical College, Kakinada. She is the best outgoing student in MBBS in 4 subjects. She got the University Gold Medal in a broad specialty MD. She also received the Mahesh Narayan Memorial Gold Medal in DM Nephrology for the academic year 2016. And her areas of interest are preventive nephrology and CAPD. And over to Dr. Ratna Prabha for her talk on the management of PRACI. Just before she gives her lecture, management of PRACI or AKI is like any other AKI, but PRACI has special problems, like we need to make sure, especially if the patient is on a dialytic therapy, we have to make sure that there are no hemodynamic disturbances which can affect the fetus. So over to Dr. Ratna Prabha for her lecture.
Very good morning to all of you. Thank you, madam, for your kind words and introducing me. And at the outset, I would like to thank Dr. Saivani, madam, for giving me this opportunity. So let us start this today's topic. Today, I will be talking about the management of pregnancy-related AKI. Yes, for the next 20 minutes, I would be talking this talk under these subheadings: the introduction into the topic and a little insight into the etiology, because most of the times it is etiology driven, and the general principles of PRACI management, which are common to all irrespective of the etiology, and the preventive aspects, because the management doesn't start once it develops. It should start early for a better overall care and the management. And the most common causes are preeclampsia, so I would like to talk about that as well. And SLE, it's of interest for the nephrologist, so I will be touching that topic as well. And the drugs and the immunosuppressants and their modifications and how to change it, I will be talking. And what way the dialysis prescription is going to be changed for a pregnant woman, I will be talking. So introduction, as it's already been introduced in a very good manner by earlier speakers. However, it's an important risk factor for early and late maternal and fetal mortality. We should always remember that we are dealing with 2 lives. So it's not an easy cakewalk, and it's like walking on a tough tightrope walk. So it's difficult to manage. So there is a world of difference between the epidemiology of PRACI in developing and developed countries. So as already dealt by the earlier speaker, so septic abortions and infections, they come to most of the causes of PRACI in developing world. Whereas in developed world, on the other hand, with the age of conception is progressing nowadays, and also increased usage of assisted reproductive techniques and late maternal age, all these factors, once again, they are increasing the incidence of PRACI. And it is a heterogeneous in etiology. Various etiologies can lead to AKI. So the incidence is increasing, and it is quite challenging, and it is a multidisciplinary approach. It's not a one-man show or one consultant oriented. So before understanding the PRACI, we must always have an insight into the etiology. As you can see in this picture, in the first trimester, it is most of the times hyperemesis gravidarum and septic abortion. And as the pregnancy progresses, these all causes will set in. However, out of all these causes, preeclampsia is the most common cause of AKI. Preeclampsia producing AKI is only 1 to 2%. But if we see retrospectively, out of all the PRACI, it's the preeclampsia which is most commonly encountered by the nephrologist. So it's a multidisciplinary approach. So it's like joining all the jigsaw puzzles. Only then we can connect the dots and we can achieve a comprehensive and a complete care. It is being shared by the fetal medicine specialist, the obstetrician, the nephrologist, and the neonatologist. So certain rules are, first things first, certain rules are common for all the causes of trachea, irrespective of the etiology. Whenever we see a patient with AKI, pregnancy related, then we must restore and maintain the fluid balance. And then electrolyte and acid balance needs to be maintained. And we should continue our nutritional support. And then prevention of infection. We should consider delivery when there is an imminent threat for the continuation of pregnancy, both maternal health as well as the obstetric outcome. When they are in jeopardy, better to terminate the delivery and avoid nephrotoxic drugs. And we should always make an effort to control the ongoing blood loss, especially that happens with abruptio placenta and placenta previa. And we should avoid diuretics by all means, as this can precipitate decreased uteroplacental perfusion and can cause fatal compromise. So what is the emergency management? Stabilize the patient. That includes airway, breathing, circulation, establishing them. And then we have to identify the underlying cause. And we should always, by all means, we should achieve adequate perfusion. And then dialysis whenever there is indicated. Just the indications are like non-pregnant state only. That is a severe hyperkalemia, or severe fluid overload, which is not amenable with medical management, and severe uremic pericarditis, or when the other uremic manifestations are seen. In that cases, hemodialysis comes to our rescue. And then fetal monitoring should always be done by regular fetal heart rate checkups and also biophysical profiling. And always the maternal health as well as fetal health are our priorities. But when one comes to compromise, then maternal health takes the priority over the fetal health. So preeclampsia, this is a very important cause of pregnancy related AKI. So all women doesn't develop AKI, those who have preeclampsia. So who are the women who likely to develop AKI with preeclampsia? This is an article showing some predictors. Out of this, the women with already pre-existing chronic kidney disease and those who underwent assisted reproductive techniques and also who delivered via cesarean section, and low socioeconomic status, these these are the individuals in whom we can predict AKI. So how will we manage preeclampsia? The drugs are methyl-dopa, libetalol, and hydrolizine as the old school teaching. So methyl-dopa is the first drug of choice, and libetalol, next we can use it. A maximum of 200 milligrams we can use, and then 40 milligrams increments over a regular 20 minutes, we can increase up to 200. And hydrolizine is a second line of drug, and hydrolizine is not completely free of side effects. It can cause maternal bradycardia and fetal bradycardia. So it's more commonly used in combination with methyl-dopa and beta blocker. Hydrolizine can be used even parenterally. Whenever you are using magnesium, when the mother is having seizures for the neuroprotection, then when you are using dihydropyridine calcium channel blockers as well, it can precipitate hypotension. And beta blockers should be avoided in the first trimester of pregnancy as they can cause fetal bradycardia. So all the risk factors for preeclampsia should be controlled, and high blood pressure will translate into AKI. That's why we must control the blood pressure appropriately to prevent AKI. So prophylactic administration of low-dose aspirin, this is very important and it should be started. Low-dose, what I mean means 81 milligrams per day, and when to start? As early as 12 weeks and better before 20 weeks, not beyond 28 weeks. So this is the low-dose aspirin, when and how to be used. And calcium supplementation should be continued. And if it is a mild disease, bed rest will be sufficient. But mild disease, I mean BP 140/90 and proteinuria less than 500 milligrams per day. And according to the 2013 American College of Obstetrics and Gynecology guidelines, this preeclampsia proteinuria is taken altogether, and proteinuria is not required anymore for making a diagnosis. So adequate fetal size and maturation should always be ensured to achieve optimal outcome. And when there is no hepatic involvement, when the platelet count is normal and there is no hemolysis, and when the serum urate level is less than 4.5, you can safely continue the pregnancy. So the optimum level at which you should start antihypertensive therapy is when in between 160 to 140 or more, then better to start. And the goal is to systolic blood pressure. When the goal is to maintain systolic blood pressure less than or equal to 140. And these are the usual drugs. And by any means, don't give diuretics or ACE inhibitors and ARBs, as they can cause fetal agenesis of the kidneys, oligohydramnias. These are the dangers when you use ACE inhibitors. And the magnesium sulfate, mild vasodilator, it is the drug of choice for preventing seizures. In the presence of seizures and HELP is always an indication for delivery. So as I already told, the flip side of hydralazine is it's not completely safe. It can cause high maternal heart rate and low neonatal birth weights. So what are the indications of delivery in preeclampsia, the fetal indications and the maternal indications? When the fetus is showing severe intrauterine growth restriction, non-reassuring fetal surveillance, oligohydramnias, then you need to terminate the pregnancy. And the maternal indications being the gestational age of 38 weeks or greater, platelet count of less than 1 lakh, progressive deterioration of hepatic when the end organs are in threat, hepatic dysfunction, be it a renal dysfunction, and then suspected placental abruption. Placental abruption is very one important cause for prachi, and identifying it promptly is very important. And usually the differentiation from abruption and previa is it is usually painful bleeding. Previa is usually painless bleeding. And even for the same amount of blood loss, abruption will go more into AKI. And persistent severe headache or visual changes, and when there is epigastric pain, nausea or vomiting and imminent eclampsia, then better to terminate the pregnancy. These guidelines are adapted from National High Blood Pressure Education Program Working Group on High Blood Pressure in Pregnancy. So as I already told you, the aspirin, so it should be started as early as 12 weeks, better to be before 28 weeks of gestation, and in a dose of 81 milligrams per day. So prophylactic low-dose aspirin is useful for the prevention of early pregnancy loss, fetal growth restriction, stillbirth, and preterm birth. So another important cause for this AKI during pregnancy is untreated and unattended asymptomatic bacteria later translating into acute pyelonephritis. So it should be treated, and at least one follow-up culture should be negative, and these are the usual drugs of choice. So Canadian Task Force on Preventive Healthcare and Canadian Task Force on the Periodic Health Examination, United States Prevent Service Task Force, all these things what I have shown here, they endorse for a regular screening as early as first trimester, and it should be treated empirically with the antibiotics mentioned before, and one follow-up culture should be negative. Otherwise, it will translate. There are high chances to go into acute pyelonephritis, AK, and uneventful outcome. I mean, dangerous outcome. 3 or more UTI in ear may require suppressive therapy. Nitrofurantoin and trimethoprim are the usual drugs of choice. High rates of asymptomatic bacteriuria are noted during pregnancy because of the anatomical changes and dilatation and physiological hydronephrosis, which can lead to infection. Untreated bacteriuria can translate into low birth weight and preterm delivery. Inciting organisms are mostly either gram-negative and sometimes even gram-positive. E. coli 70%, Klebsiella, Enterobacter 3%, and Proteus 2%. Fluoroquinolones and aminoglycosides should be avoided. So next important topic is SLE and pregnancy. Only the management issues and preventive and treatment issues, not into the pathophysiology. So when a woman shouldn't become pregnant, so severe pulmonary hypertension, wherein I mean systolic pulmonary artery pressure more than 50 mm of mercury, severe restrictive lung disease, I mean forced vital capacity less than 1 liter, advanced renal insufficiency, that meaning creatinine more than 2.8, advanced heart failure, previous severe preeclampsia or HELP despite therapy, and pregnancy can be postponed. In the above indications, altogether a big no. In the lower 3 indications as shown in the table, it can be postponed to a later date. When the disease is severe, having a severe flare in the last 6 months, if the disease is active, and stroke within the previous 6 months, we can counsel the mother to postpone the pregnancy date. So assess them for any major organ dysfunction. This is a flow diagram showing how to approach SLE woman when she becomes pregnant. So first in the first visit, you should assess for the major organ dysfunction. Advise against pregnancy if there is already existence or evidence as I shown in the table. So assess for the disease activity. If it's stable, you can proceed. If it is active, defer pregnancy. Obtain an autoantibody profile for risk evaluation, especially antiphospholipid antibodies and anti-Ro antibodies, and review the medications and avoid the teratogenic drugs and change her to safe drugs and control the blood pressure. So these are the drugs. These are the drugs which needs caution. Corticosteroids, the metabolism is mostly placental and the risks are not so much. And however, the corticosteroids can cause maternal medical complications like hyperglycemia, hypertension. So better to avoid. But if the clinical condition of the patient warrants their usage, then reduce it to as much as possible. If the disease is severe, then you can give pulse doses of steroids instead of giving prolonged doses of steroids. And the FDA class has shown in the table. So hydroxychloroquine, it is the only drug which has been proven and it should be continued throughout life for a SLE woman. And the same thing holds even for pregnancy. It should be given between 200 to 400 milligrams per day. And discontinuation during pregnancy is associated with increased risks of flares, may use for maintenance of mild flares. So NSAIDs, they should be avoided, especially in the last trimester, because premature closure of patent ductus arteriosus has been reported. NSAIDs also better to avoid, but if the condition is requiring, then better to use in the first trimester and second trimester. Then cyclosporin can be maintained pregnancy at low effective dose. And tacrolimus, then it can be maintained in pregnancy at lowest effective dose. Tacrolimus, potential risks of neonatal hyperkalemia and renal dysfunction are reported in the literature. Rituximab, is it a safe drug, or there is limited data about the safety of rituximab? And then when the lupus flare is not responding to your regular drugs, then you can try rituximab. And IVIG is reported to have increased thrombotic episodes, so better not to use unless it is resistant to the aforementioned drugs. So azathioprine may use for flare during pregnancy. It should be considered as an alternative to mycophenolate mofetil. So my MMF is contraindicated during pregnancy. And cyclophosphamide also, it's a life-threatening drug. It's teratogenic drug. Unless the disease is so life-threatening, don't use cyclophosphamide, and better to avoid by all means. But recent studies, it's less pronounced, not that high risk of fetal loss has been reported. But however, during the period of organogenesis, better to avoid cyclophosphamide by any means. Then methotrexate, a big no, it's contraindicated during pregnancy. So this is an article published American College of Rheumatology, and the conclusion of this is we recommend the continuation of HCQ throughout the pregnancy, and this is useful for preventing flares and good outcomes, useful for promoting good outcomes. HCQ is not associated with any congenital defects or spontaneous abortions or fetal death or prematurity, and it is safe even from a fetal development perspective as well. And it decreases the chances of adverse neonatal outcomes. So to sum up, SLE during pregnancy, so we should always focus on the fetal as well as maternal disease related issues, and complexity further increases with SLE because SLE alone is not going to have the clinical picture. SLE with superimposed preeclampsia, accelerated hypertension, and a brachy, and this translating even into early abruption, hemorrhage, all these may go hand in hand. In these disease entities may not come as a separate, distinct entities in clinical practice. They may usually coexist. So identifying a good antenatal and a prenatal counseling is very important to achieve a good outcome and prevention of pregnancy-related AKI. Treatment of flares, that is all that I already discussed, and steroids, HCQ, and these are the usual drugs that we prescribe during pregnancy. So if it is an APLA, you have to categorize them. If they are asymptomatic and they are not having any bad obstetric history, then you should give aspirin. If the obstetric antiphospholipid syndrome history is there with or without thrombosis, give aspirin with prophylactic doses of heparin. If the APLA diagnosis is already established, then give therapeutic doses of heparin until 6 weeks of postpartum. So is it the kidney biopsy required during pregnancy? Better to avoid kidney biopsy during pregnancy unless you feel that it is seriously going to alter your treatment. And otherwise, better to avoid the renal biopsy because it's associated with increased chances of bleeding and the positional difficulties. All these are there. And if there is a nephrotic syndrome or a crescentic glomerular nephritis is suspected or severe anuria, then you are not having any clues to the etiology, then only do a biopsy. Better even then, the biopsy should be planned in the postpartum if possible. So what way the dialysis of a pregnant woman is different from normal our regular dialysis, what we see in our practice? We should use a low flux dialyzer. High flux dialyzer is associated with more chances of infection, sepsis after the dialysis. So better to use a low flux dialyzer and avoid hypotension because that will cause the fetal compromise. So by all means, we should continue to achieve good uteroplacental perfusion every time. So avoid hypotension. How to avoid hypotension? Start with a blood flows of 180 to 300 in the first half an hour and gradually increase. Don't start the dialysis in the first half an hour itself with high blood flows. So avoid abrupt osmolar shifts. They are detrimental to the developing baby. And high surface area membranes because we want to maintain the uremia to a lower level and the cutoff should be less than 40. There is actually very limited number of data in the literature to get these sources of information. Most of the times it's being extrapolated from the ESRD dialysis pregnant woman. However, with the available literature for AKI, pregnancy-related AKI, high surface area membranes are used. And the pregnancy itself is a hypercoagulable state. So there will be increased requirements of heparin as long as there is no active vaginal bleeding. You are safe to use heparin. And hemodialysis in pregnancy, as there is a requirement, it's a highly, it's a state of high requirements. So nutritional supplementation and is very important throughout the pregnancy. That holds good even during dialysis. So 10 to 15 grams of amino acids are lost in the dialysis. You have to supplement 1.5 to 1.8 grams per kg per day is recommended, plus along with the daily recommended dose. So extra losses plus daily dose, and that is the recommendation. So how much energy, how much kilocalories means it is 35 kilocalories per kg plus extra 300 kilocalories per day should be supplemented. The folic acid and water soluble vitamins should be given, and the calcium supplementation increase the dialysate calcium, and also in addition to oral supplementation of 1 to 2 grams per day. So your HD prescription should also make a mention about the potassium content of the dialysate. It should be 3 to 3.5, and already a hypokalemic state will prevail. So that's the reason. And bicarbonate concentration should be 25 milliequivalents per liter. It's a respiratory alkalosis state with a compensated metabolic acidosis. So we don't want any osmolar shifts which are detrimental to the developing fetus. That is why these precautions must be observed. The calcium in the dialysate should be adjusted as mentioned here, and the sodium in the dialysate concentration should be 135. So the left lateral decubitus position is the preferred position. So a small note about the renal transplant recipients. So whenever a ESRD patient comes to us saying that she wants to become a pregnant, first encourage her to undergo transplant and then pregnancy, because the chances of conception will increase, and the outcome in terms of baby also is better when she undergoes transplant first. And the graft rejection is actually the literature shows doesn't say either increased rejection or decreased rejection, because it's a pregnancy, is an immunotolerant state. So actually the chances are low, but because of the change in the drug regimen and the pharmacokinetic changes that happens, there are reported otherwise. So the drugs we should change to less teratogenic and safer drugs during pregnancy. And CNI levels should be kept to a lower threshold. What you routinely achieve those thresholds, if you apply here, you will be precipitating CNI toxicity without our knowledge. So CNI levels monitoring should be frequent and it not too enthusiastic targets. So this is the table showing how to deal and how to prevent and how to manage AKI in a woman who already underwent transplant. According to KDIGO, at least the graft function should be stable for 1 year, but many, they recommend for at least 2 years, the stable graft function, then only she should undergo a transplant. best pregnancy outcomes will occur if pre-pregnancy creatinine is less than 1, proteinuria is less than 500, and blood pressure is less than 140/90. Your aspirin should be continued throughout the pregnancy. That is helpful for prevention of preeclampsia. And then replace all medications that are not safe in pregnancy, eradicate UTI and prevent all the infections, and continue cyclosporin, tacrolimus, and monitor them at frequent intervals and achieve a lower threshold, lower target threshold, and test and control the diabetes and monitor it. Be vigilant for that because it may develop, because already on steroids. During pregnancy, visit, if this is algorithm when and where she has to visit a nephrologist. So to sum up, what are the causes of pregnancy and their related treatments? If it's a hyperemesis gravidarum and the prerenal cause, hydration is the key, and septic abortion and urinary tract infection, give appropriate antibiotics. Preeclampsia or HELP or acute fatty liver of pregnancy, delivery is the mode of management. TTPs, plasma exchange and rituximab. Atypical hemolytic uremic syndrome, eculizumab. Obstructive uropathy, take a surgical opinion. Placental abruption and hemorrhage, control the bleeding and delivery, and give appropriate blood and blood products if required. Glomerulonephritis, go ahead with immunosuppression. So to take home message, 75% of AKIs occur in the late third trimester and early postpartum. Treat and identify and treat always the underlying cause. It's not straightforward, it's heterogeneous because the causes are different, the diagnosis is difficult to establish, and there are no standard criteria for making a diagnosis, and even a lower threshold for creatinine to make a diagnosis of AKI. Most of the times it's a late referral because obstetricians won't be having that much insight that serum creatinine cutoff of 0.8 needs to be considered. And throughout the pregnancy, you have to maintain appropriate supportive care to establish good uteroplacental perfusion, and always fetal health and maternal health, you have to manage both. And preeclampsia and HELP, they are the most important causes. And HELP, is it a variant of preeclampsia or is the continuum? It's a new understanding is evolving. And all the researchers are pondering that HELP is a new entity rather than this, because the amount of proteinuria is higher and the chances of AKI of a woman with HELP are more than with preeclampsia. It's the same spectrum or a different spectrum needs to be still, it should be brought into the light. And septic abortion, perpural sepsis, APH, PPH, these are the other causes of AKI. They should be managed appropriately. Thank you.
Thank you, Ratnaprabha, for lucid presentation on management of PROCI. And I request all the participants type your questions in the chat box for the speakers. And over to you, Anuradha Madam, for commenting on Ratnaprabha's lecture.
Yeah. Congratulations, Dr. Ratnaprabha, for that exhaustive discussion on the various management aspects of pregnancy with PROCI. Although we know specific diseases, treatment is straightforward, simple, but in a pregnant state, pregnancy-related AKI with underlying comorbidities, underlying renal dysfunction, it requires special care because we need to look at both the mother and the fetus. As Saivani says, discussion will be towards the end. I hand over the mic to Saivani for further deliberations. And once again, congratulations, Dr. Ratnaprabha, for that very lucid and informative presentation.
Thank you, Madam, for your encouraging words. Thank you.
Thank you, Madam. Next, we move on to next lecture, that is specific disorders in pregnancy, HUS AFLP. And this is by Dr. Sharad Joshna. And for this session, the moderator will be my teacher, Dr. PN GK Madam. GK Madam did MBBS from Kilpauk Medical College, Chennai, MD from Kurnool Medical College, Kurnool, and DM from Usmania Medical College. And she is a retired professor and HOD of Nephrology, Kurnool Medical College, and retired additional DME and principal, Kurnool Medical College. Madam had many international and national publications, and she had given many guest lectures, and she had organized CME speech programs in Kurnool Medical College, and even as a AP Society of Nephrology. She is a vice president of AP Society of Nephrology, and she is backbone for our WIN AP chapter, and she is the president of our WIN AP chapter. Over to you, Madam.
Thank you, Dr. Saivani. Now I take the privilege to introduce the speaker, Dr. P. Sharad Joshna. She has done her MBBS from Andhra Medical College, Vizag, and MD from Usmania Medical College, Hyderabad, and DM from Andhra Medical College, Vizag again. She worked as assistant professor in Karnool Medical College, Karnool. She has been a very good junior colleague to me. And presently she is working as assistant professor, Government General Hospital, Srikakulam. She has achieved a gold medal in her MBBS, and she has a few publications like Spectrum of Non-Diabetic Renal Disease in Patients with Diabetes and Pulmonary Manifestations in Rheumatoid Arthritis. Over to Dr. Sarath Jyotsna to deliver her lecture here. And about
Sharath
the
Jyotsna,
topic,
madam.
1 minute, about the topic. It's so unfortunate that the last speaker has very little to talk on because part of it has been covered by the, her topic has been covered by the predecessors. Over to Sarath Jyotsna.
Very good morning to respected teachers, my colleagues, and I am very fortunate to work under Dr. Jikki Madam. She has been continuous inspiration to me and to many budding nephrologists. I am very fortunate and thank you, Madam, for your great support throughout my journey in the Karnool Medical College. I am very grateful to you, Madam. Now coming to the topic, today I am going to deal with the specific entities like hemolytic uremic syndrome, health, and acute fatty liver of pregnancy. Is it visible?
No, madam. Share the screen.
Sarath, you are visible, but you share the screen for the slides. Slide sharing.
Yeah, madam. Now it is visible.
Yeah.
Thank you. Half of my job was done by previous speakers who extensively discussed about these entities partially also, and treatment was completed covered by Ratna Prabha.
Go to
So,
slideshow.
Slide. So, coming to the hemolytic uremic syndrome, first we will have a brief discussion about the complement system. Complement system is a part of innate immunity. The complement system helps us in protecting against.
Madam, go to slideshow, madam.
Share your slides, ma. Dr. Sarath.
I am showing, ma'am. Is it visible, ma'am?
Screen is visible, madam. This one, this cup-like thing, you have to click on that. Then
Yeah, you are not on slideshow.
Otherwise, Bashir, you share the slides of Madam Bashir.
I think you will have to click on enable editing also. Slides are not.
1 second, ma'am. We are sharing.
Bashir, start from this. Share from the starting beginning. Yeah, from first slide.
Ma'am, which slide do you want us to share, ma'am?
From the first. Yeah. Start slideshow. You do enable editing and then start slideshow. Here, this one.
Enable editing, Bashir.
Is it visible?
Madam, please start slideshow, madam. First do enable editing, then start slideshow. And share your screen.
I already shared my screen.
No.
This is Bashir. This is Bashir's screen, video conference screen, no?
Yes.
Bashir, enable editing. It's there, no, in the white at the top, and then go to slideshow. Bashir, are you there? Bashir?
Yes, ma'am. Yes, ma'am.
Do Bashir, do enable editing.
You first click on enable editing. Yeah.
Yes. Bashir, you can mute yourself.
Yeah, it's
Now
fine.
I'm going to discuss about the hemolytic uremic syndrome, HELP and acute fatty liver pregnancy. Previous speakers have covered most of the topics which now I supposed to cover. So today I'm going to discuss about complement system, which is a part of innate immunity. Slideshow is not visible, ma'am.
You're on slideshow.
Bashir, change the slides. Otherwise, Madam Sharad Joshna, Madam, you only share the slides, then you can change the slides.
Next. Okay. Now you are there, Sarath, go on.
Okay. Complement system is a part of innate immunity which helps us in protecting against the invading organisms, which helps in removal of the debris from the plasma, tissue, and enhancement of the cell-mediated immunity. It also helps in the phagocytosis and antibody-mediated immunity also. Pregnancy is per se which triggers the complement activation because there is an immunological conflict takes place in the placenta, which is an interface between the semi-allograft, that is fetus, and the mother. Next slide, please.
Bashir, next slide.
This is a picture showing what there are three pathways in the complement system cascade, that is classical pathway, lectin mediated pathway, and alternative pathway. Whatever may be the pathway of activation, whether it is a classical, lectin, or alternative pathway, all will converge at the C3 convertase, from where there will be release of the membrane activating complex when the tissue injury occurs. There are several regulatory proteins which control the activation of the complement system, like factor H, factor I, and membrane cofactor protein and decay accelerating factor. These are going to inhibit at the level of C3 convertase. There are some activating proteins like factor B, C3 coding genes, which activate the complement cascade. Activating mutations of the genes involved in these proteins will lead to continuous activation of the complement system, complement cascade, and abnormalities of the complement mediated tissue injury. Placenta is subjected to complement mediated immune attack at the help of attack in the feto-maternal interface with the risk of fetal loss. In normal pregnancy, the placental trophoblast cells express decay accelerating factor, membrane cofactor protein, and CD15, which are expressed on the surface of the trophoblasts.
Dr. Sharath, I think your slides are not moving.
Bashir, you stop sharing. Sharad Joshna, Madam, you only share the screen, then you can change the slides.
Actually, I didn't get the option of sharing, ma'am, here.
Have you logged in through speakers only, no, Madam? Speakers.
Yes, yes.
Then in the down there, after the chart, there was a share screen option.
Yes, that previously that used to be there, but once they applied the enable setting, I am not getting the slide share mode.
Then you request the Bashir to change the slide.
Can I share, ma'am, because your slides are.
Ma'am, I'm giving remote control, ma'am. You can share yourself. So who should I give remote control, ma'am?
Sharad Joshna.
Me,
Sharad
speaker. Yes.
Now you can control, ma'am.
Bashir, start slideshow.
No. How to control this one? I'm not getting any remote. Okay.
Bashir, slideshow. Please keep slideshow. Okay.
No, I'm unable to control these slides, which is not, the control is not under me. Yes, now I could able to control.
Okay.
Placenta is subjected to complement-mediated immune attack at the feto-maternal interface, which leads to the risk of fetal loss. In normal pregnancy, these complement regulatory proteins like decay accelerating factor, membrane cofactor protein, and CD59 are expressed on the surface of the trophoblasts, which helps in the complement activation, which helps in the control of a complement activation. There are factors like as the gestational age increases, there is increase in the complement activating proteins like C3, C4, and CH50. This is the reason pregnancy per se is a complement activating physiological condition. After delivery, the inflammation per se because of the delivery and the release of fetal cells into the maternal circulation, infections and hemorrhage, which leads to the activation of the alternate pathway, even in the absence of the regulatory mechanisms which are present on the placenta, which induces postpartum HUS. That is the reason among the all TMAs, postpartum HUS is most common after postpartum when compared to the TTP and the preeclampsia which are present in the antepartum state. The risk of pregnancy-related atypical HUS was highest during the second pregnancy. TMA refers to a group of syndromes with multiple etiologies, including both hereditary and acquired, that have characteristic microvascular platelet thrombi, which leads to microangiopathic hemolytic anemia, thrombocytopenia. Most common variant of subtype of TMA is the Shiga toxin-induced hemolytic uremic syndrome, which is common in children, which is caused by the Shiga toxin, which is produced by the enteric pathogens like Shigella dysentery, Shigella flexneri, and enterohemorrhagic E. coli O157 and H7 subtypes. The clinical presentation will be several days of abdominal pain associated with bloody diarrhea, and after the subsidence of the diarrhea, 15% of the individuals will develop acute kidney injury. Usually the hemolytic Shiga toxin related hemolytic uremic syndrome recovers spontaneously, and the recurrences are rare. The history suggestive of Shiga toxin related hemolytic uremic syndrome, like exposure to intake of unpasteurized milk and the intake of ground beef and contaminated food and beverages, which leads to gives a clue that the person might be suffering from the Shiga toxin related hemolytic uremic syndrome. Here in Shiga toxin related hemolytic uremic syndrome, preceding antecedent infection followed by diarrhea, and later the person develops acute kidney injury. There are some entities like AKI develops even without diarrhea, and it is often recurrent and persistent disease. And some have the family history of atypical hemolytic uremic syndrome. So if you take adults, half of the cases will be complement-mediated hemolytic uremic syndrome, half will be toxin related. So previously in olden days, there is an entity called atypical hemolytic uremic syndrome. With the advancement of the literature and research regarding complement cascade and the identification of the various genes involved in the complement cascade, that nomenclature has been replaced as complement mediated hemolytic uremic syndrome than the atypical hemolytic uremic syndrome. Pregnancy is the trigger factor for the complement mediated complement-mediated thrombotic microangiopathy, which is also called pregnancy-related atypical hemolytic uremic syndrome. TTP is a TMA causes microvascular symptoms in the organ systems other than kidney, characterized by pentad of microangiopathic hemolytic anemia, thrombocytopenia, fever, neurological symptoms, and the acute kidney injury. The clinical manifestations, neurological manifestations being like any severe preeclampsia, eclampsia like headache, confusion, coma, stroke, seizures, and stress. If you take complement-mediated thrombotic microangiopathy, they can be inherited deficiencies or inherited genetic abnormalities, which leads to continuous activation of the complement factors, and the acquired abnormalities like development of autoantibodies which inhibit the regulatory involvement of the regulatory proteins. There are very few studies regarding complement-mediated TMA in pregnancy. There is one French study in which 100 adult female patients were studied, out of which 21 patients have pregnancy-related atypical HUS, also called complement-mediated thrombotic microangiopathy. Out of these 21 patients, 18% have complement abnormalities, and 1% has family history of hemolytic uremic syndrome, and there is earlier presentation of nephrotic syndrome in the 4th month of gestation in the second pregnancy, whereas remaining 12 out of 21 patients had one or more pregnancies prior to this episode of hemolytic uremic syndrome. 3 patients were presented with preeclampsia during pregnancy, complicated by pregnancy-related hemolytic uremic syndrome. When compared to the other disorders of TMA, the renal involvement is severe in complement-mediated TMA, and 62% have reached end-stage renal disease. Thrombocytopenia in this study is very moderate. None of them had neurological abnormalities, and 6 pregnancies had led to live births, which is when 1 pregnancy was complicated by early fetal loss. Thrombotic thrombus and TTP is caused by the severe Please share previous slides.
Bashir.
TTP is caused by severely deficient activity of ADA-MPS, which is a metalloprotease which is produced by the hepatic stellate cells and megakaryocytes and endothelial cells. TTP is caused by the severely deficient activity of the ADA-MTS13. As the pregnancy increases in the second and third trimester, the ADA-MTS activity decreases because of the increased production of the von Willebrand factor. Because of the consumption of one ADA-MTS in the cleavage of von Willebrand factors, as the gestational age increases, there is reduction of the ADA-MTS levels in the pregnancy. In early preeclampsia, before 20 weeks of gestation, which is a characteristic of hereditary TTPs. If you take TTPs, there are two subtypes, that is hereditary TTP and immune-mediated TTP. Hereditary TTP is because of genetic deficiency of ADMTS13 activity, which triggers following pregnancy, especially in the second and third trimester. Whereas immune-mediated TTP, the occurrence is equal throughout the gestational age. Immune-mediated TTP is common in young females and especially blacks. The diagnosis of TTP is based on the clinical
Bashir,
and
8th slide.
laboratory
Please share
parameters.
the 8th slide, Bashir. 8th
So
slide.
the diagnosis of TTP is predominantly by the clinical and laboratory parameters, and the plasmic score, which is having 7 components, helps in the diagnosis of TTP.
Next slide.
The components of the plasmic score being platelet count less than 30,000 and one or more indicators of hemolysis like increased reticulocyte count more than 2.5%, decreased heptoglobin levels because of the hemolysis, and indirect bilirubin levels increases more than 2 milligrams. And other features like decreased mean corpuscular volume less than 90. This criteria of MCV less than 90 was included in plasmic score because some metabolic abnormalities of B12 and the severe B12 deficiency which causes ineffective erythropoiesis, the presentation will be similar to microangiopathic hemolytic anemia which is present in the TMA syndromes. So that's why MCV volume less than 90 gives a clue that you are dealing with a case of TTPs than the B12 deficiency or B12 metabolic abnormalities. Because in B12 deficiency, the MCV volume will be more than 90. There shouldn't be any history of active cancer in the preceding years, and no history of solid organ transplantation or hematopoietic stem cell transplantation. These two were included because history of cancer, malignancy related hemolytic uremic syndrome, and post-transplant chemotherapeutic drugs or immunosuppressive drug induced thrombotic microangiopathies. And INR of less than 1.5. This criteria helps in differentiating between acute fatty liver of pregnancy and where INR tend to rise more than 2 to 4 times. The creatinine level less than 2 milligrams per deciliter. So out of these 7 criteria, if the criteria, each point was allotted to one entity. If the cumulative score is 0 to 4, there is a low risk of the diagnosis of less possibility of TTP, and if the score is 6 to 7, there is high possibility of ADMTS13. This gives the clinical confirmation of ADMTS deficiency, and patient needs either has to be treated with the therapeutic plasma exchange or plasma infusion. If you are dealing with a case of if there is previous history of similar episode and the suggestive of hereditary TTP, then plasma infusion is sufficient. Whereas if you are dealing with immune-mediated TTP, the plasma exchange has to be given. There are primary TMAs like TTP, complement-mediated TMAs, and drug-induced TMA. Again, drug-induced TMAs are two entities, immune and non-immune mediated. Immune-mediated drug-induced TMA are common with quinine, gemcitabine, and non-immune mediated are common with the recreational drug abuse like cocaine and oxymorphone and bortezomib. Next, the clinical presentation and clinical picture of TMA also present with some other systemic diseases like systemic lupus erythematosus. Here, the previous history of SLE and with ACR criteria and presence of lupus nephritis features and the persons are on immunosuppressive drugs for SLE, which history gives a clue for the diagnosis of SLE, and catastrophic APLA syndrome, antiphospholipid antibody syndrome, which have features of microangiopathic hemolytic anemia. But here the differentiation being in catastrophic APLA syndrome, there is a large vessel thrombi will be there, whether it is arterial venous thrombi. Whereas in TMA, it is a microvascular thrombi. Scleroderma renal crisis, the limited cutaneous scleroderma, cutaneous dermatological manifestations, and presence of renal artery stenosis will give a clue that you are dealing with a scleroderma renal crisis. And Dick sepsis. Here in Dick, the presence of thrombocytopenia and preceding history of infection and source of infection and conjunctive coagulopathy and elevated levels of D-dimers and decreased fibrinogens gives a clue that you are dealing with a Dick. And prosthetic heart valve will also give a picture of microangiopathic hemolytic anemia. That's why while evaluating the case of suspected TMAs, we have to rule out all these systemic diseases which may give you a clinical picture of microangiopathic hemolytic anemias. So when you are dealing with a postpartum or peripartum TMAs, we have to keep it in mind like placental abruption with Dick, which gives a similar picture, and the preeclampsia with severe HELP syndrome and other TMA syndromes. So how you are going to evaluate and come to a conclusion that you are dealing with a case of TMS? The history of triggering factors like pregnancy, surgery, infection, and other inflammatory conditions and autoimmune flares, and history of cancer and the history of usage of chemotherapy drugs. And exposure to farm animals and undercooked meat, which gives a clue that you are dealing with a shigotoxin related TMA, and diarrhea with blood in the stools. So here the one entity is if you are dealing with a case of AKI with diarrhea with blood in the stools, it could be a shigotoxin associated or it could be a part of catastrophic APLA or severe TTPs. In shigotoxin associated, the bloody diarrhea subsides, later renal failure develops. Whereas in case of TTP or catastrophic APLA syndromes, because of the intestinal infarctions, the onset of bloody diarrhea may present after the onset of renal failure.
Can
I interrupt? I think the slides are not at all moving. Saivani, can you please look at that?
Yes, madam. Bashir.
There is so much of, she's talking, but the slides are something else.
Actually, control is not
madam, madam, here it is showing Charathosna madam is controlling your screen like that.
But I couldn't control, ma.
You change this, otherwise you change this one. Like that. Is it okay, madam, now?
No, it's not.
Twelfth slide, madam.
Jyotsna, are you able to see the slides that you're talking about? Or yeah? Then why don't you change once you finish that slide? Because
no, ma'am. Actually, I'm unable to control here.
Mari meer maatladedi ela? How are you talking?
I'm just speaking of madam.
You are only controlling the system.
Shall I close it and reopen, ma'am?
Ma'am, otherwise, shall I present your slides because you already sent it in the group? Anyone can share your slides, right, ma'am?
Okay, Ratna, you take over the screen.
If you
then
stop sharing, I can start sharing, ma'am.
Yeah, I think that's better.
Is it visible, ma'am, for everybody?
Yeah. Yeah, Ratna.
Ratna, you move on.
Where to stop, just let me know, ma'am. From then on.
13th slide. Next slide. Next slide. Yeah.
Yeah. Thank you.
Go on, Sarat.
Okay, ma'am. In the 12th slide, The presence of on the history and evaluation, you have to
Previous
look
slide,
at
Ratna. Previous slide.
12th slide.
Next. Yeah. Is it okay, madam? Sharad Joshna?
Yes. History of on evaluation, you have to check for the history of triggering factors like pregnancy, surgery, infection, and other inflammatory conditions, and autoimmune flares, cancer, and chemotherapy, and exposure to farm animals and undercooked meat will give you a clue that you are dealing with sugar toxin related HUS, and diarrhea with blood in the stools. In sugar toxin related, the blood in the stools subsides, and after that the person develops renal failure. Whereas in case of TMAs and APLAs, the renal failure precedes the blood in the stools because of the intestinal infections and ischemia. The family history of TMA, unexplained renal failure, and death during pregnancy will give you a clue that probably you are dealing with a case of inherited complement mediated TMAs. And the extent of oral intake, most of the peripartum and postpartum females, the impressions like nil by mouth, then because of the decreased oral intake, they may land up with prerenal AKI. So probably this history will give you a clue you might be dealing with a case of prerenal AKI, then the thrombotic microangiopathies or renal failure because of other entities. And history of previous autoimmune diseases like SLE and scleroderma. Coming to the lab parameters which helps in the diagnosis are complete blood picture which shows thrombocytopenia and leukocytosis if you are dealing with a case of infection related or sepsis, and peripheral smear. If you are dealing with a case of TMS, this peripheral smear show cystocytes and spirocytes, which are the hallmarks of the hemolysis, that is microangiopathic hemolysis. And RFT, complete urine examination. Complete urine examination may be normal in few subset of patients and may be having underlying proteinuria and active urine sediment if you are dealing with a secondary APLA syndrome or SLEs. LDH again elevated in case of hemolysis, and Coombs test has to be done because Coombs test will, if it is positive, then it gives a clue that maybe you are dealing with autoimmune hemolytic anemia. The plasmic score we have discussed already, and French score also gives it helps in the diagnosis of TTP, which is having two parameters like serum creatinine and platelet count, and ADA MTS 13 activity which has to be analyzed, and the blood culture, stool culture, and sugar toxin, and complement to testing for the inherited abnormalities and genetic testing. All these things will help in the diagnosis of TMS. In the CUE, muddy brown cats gives a clue diagnosis of ATN, and RBC cats indicate that might be you are dealing with acute glomerulonephritis. Other laboratory parameters which are specific for TMEs are, next slide please, measurement of plasma. Next slide please. Next slide please. Hello. Hello.
Yes, ma'am. Is it not that one?
Yes. Measurement of plasma samples of factor H, factor I, which are measured by ELISA method, and factor B, C3, C4 are measured by nephelometry. And genetic testing for the pathogenic variants of complement genes helps and gives a clue in the diagnosis and treatment of this TMAs with anti-complement therapy. Renal biopsy. Renal biopsy is performed as a part of evaluation of the unexplained AKI. The advantage of renal biopsy is it can confirm the diagnosis of TMA, but it does not specify which type of TMA you are dealing with. And hence this biopsy doesn't give you a clue which treatment has to be followed, but it gives the confirmatory diagnosis of TMA. And one thing we have to keep it in mind, as it is a minor invasive procedure, the platelet count should be more than 50,000. And if it is less than that, as a part of that clinical picture, we have to give platelets transfusion. Another advantage of renal biopsy is to identify the extent of ischemic injury and the degree of irreversible kidney injury. And renal biopsy also helps in the diagnosis of renal limited TMAs like Shiga toxin HUS, complement mediated TMAs, APLA, and drug induced TMAs. This is a slide showing the large one. This is a large one showing lymphocyte, and these are the platelets, and it is a red blood cell, which is a normal morphology. Next slide, please. Here, these are the fragmented RBC and the helmet cells. This large arrow showing this is helmet cell, and this is the fragmented RBC, and this arrowhead, large arrowhead is showing the spirocytes. And here in this smear, the platelets are relatively reduced, and this is the enlarged platelet, nearly damp platelet. So how you are going to manage? This management part has been covered by previous speakers, so I am not going into detail. Only brief discussion specific about the TMA I will discuss. So if you are dealing with a TTP, management depends whether it is a immune mediated or hereditary. Hereditary, you have to give plasma infusions, whereas in autoimmune mediated TTP, we have to give plasma exchange. In complement mediated TMAs, where the complement blockade is not available, there also you can use the treatment of therapeutic plasma exchange. This is a slide showing once you are dealing with a case of complement mediated hemolytic uremic syndrome, start anti-complement therapy. So before starting anti-complement therapy, try to obtain genetic testings, which is not practically feasible in most of the settings. This genetic testing involving the complement factor H autoantibodies and complement factor H I and membrane cofactor proteins. So once you have sent the complement these testings, if there is complement factor H autoantibody titers are more than 1000, it gives confirmation of that you are dealing with complement mediated HUS. In that case, we have to continue anti-complement therapy till the antibody titers are less than 1 in 1000. If the results of genetic testing is not specific, then you might be dealing with complement HUS or not. If you are getting the positive test for one variant of complement, then you have to continue anti-complement therapy. Whereas if there is the sequence variant of uncertain significance is present in that, then we have to suspect complement mediated HUS. In that case, the course of anti-complement therapy is transient and it should depend on the response of the patient. So how long we have to continue complement therapy? So what are the recommendations for anti-complement therapy? The recommendations for anti-complement therapy, next slide please. Recommendations for anti-complement therapy are TMA with progressive deterioration of the renal function and TMA in pregnancy and postmortem, and the family history suggestive of TMA and the lack of features of other causes of complement mediated TMA like drug-induced TMA and Shiga toxin HUS, we have to start anti-complement therapy if there is available. So the drug of choice in complement therapy are eculizumab and ravulizumab. Both are monoclonal antibodies directed against the C5. Both have similar efficacy and safety, except the difference being the duration of action. Eculizumab has to be administered as 900 mg once weekly dose. It has to be given for 4 weeks, followed by 1200 mg 1 week after the last dose of induction. And maintenance therapy has to be given with 1200 mg of eculizumab once in every 2 weeks. Whereas ravulizumab 2700 milligrams of loading dose has to be given and maintenance dose of 3300 mg every 8 weeks, 2 weeks after the loading dose. Most of the studies haven't advised the combining anti-complement therapy with the plasma exchange. So how long we have to continue this therapy? If the patient is in remission and don't have any pathogenic variant of complement genes and testing, better to discontinue anti-complement therapy. And eculizumab can be administered safely during pregnancy and breastfeeding also. Data on potential adverse fetal and neonatal effects is limited. Hence, it can be continued during the pregnancy and in the breastfeeding period also. Another entity which comes in the differential diagnosis of thrombotic microangiopathy, complement mediated TMA is antiphospholipid antibody syndrome, which is an autoimmune multisystem disorder characterized by arterial, venous, or small vessel thromboembolic events or pregnancy morbidity in the presence of persistent antiphospholipid antibodies. This antiphospholipid antibody can be primary or secondary. Secondary mostly because of the systemic lupus erythematosus. There are three major antibodies which helps in the diagnosis of APSR: IgG anti-cardiolipin antibody, lupus anticoagulant test, and anti-beta-2 glycoprotein antibodies. This triple antiphospholipid positivity is the main risk factors for the recurrence of APLA in the future pregnancies also. Antibody testing is performed at the time of presentation of the clinical event and more than 12 weeks after the event also. So this gives the person is having a persistent antiphospholipid antibody syndrome. The persistence of these antibody titers gives a clue that the person is dealing with antiphospholipid antibody syndrome. Next slide, please. The Sydney criteria and revised Sapro criteria, which helps in the diagnosis of antiphospholipid antibody syndrome, is either one clinical and one laboratory criteria. Clinical criteria includes vascular thrombosis, pregnancy morbidity. This vascular thrombosis, one or more episodes of arterial, venous, and small vessel thrombosis. Pregnancy morbidities include one or more episodes of unexplained fetal deaths beyond 12 weeks or 10 weeks of gestation, or one or more episodes of premature births in a morphologically normal neonate before 34 weeks of gestation because of eclampsia, pre-eclampsia, or placental insufficiency, or three or more episodes of spontaneous pregnancy loss in less than 10 weeks of gestation unexplained by chromosomal or maternal anatomical hormonal clauses. So any of these one clinical and the laboratory parameter confirm the diagnosis of antiphospholipid antibody syndrome. There is another entity called catastrophic APLA, antiphospholipid syndrome. There are subset of patients with antiphospholipid syndrome has widespread thrombotic disease with multi-organ failure. The key features of catastrophic APS include previous history of antiphospholipid syndrome, 3 or more new organ thrombosis within a week, and the biopsy confirmation of microthrombi, and exclusion of other causes of multi-organ thrombosis or microthrombosis such as DIC, heparin-induced thrombocytopenia, and TMA. Here, DIC is a systemic disease with widespread activation of the coagulation and fibrinolysis. Here, there is elevated D-dimer levels and low levels of fibrogen and more levels of fibrin degradation products. And when compared to the catastrophic APLA, coagulation abnormalities elevated PT and IPTT will be there, and the risk of severe thrombocytopenia is more in DIC when compared to the catastrophic APLA, and more bleeding in case of DIC when compared to the catastrophic APS. Heparin-induced thrombocytopenia, here there will be a temporal relationship between the heparin exposure and the onset of thrombocytopenia. And differentiation between the TMA doesn't include large vessel thrombosis. Another entity is acute fatty liver of pregnancy. This acute fatty liver of pregnancy is characterized by maternal hepatic dysfunction and microvesicular fatty infiltration of the hepatocytes. Acute fatty liver of pregnancy is relatively rare when compared to the other pregnancy events, with incidence being 1 in 7,000 to 20,000 pregnancies. The risk factors for acute fatty liver of pregnancy are multiple gestation, prior acute fatty liver of pregnancy, and male sex of the fetus. This male sex of the fetus is because of there are some hereditary enzymatic abnormality which helps in the mitochondrial beta fatty acid oxidation. Because most of the mitochondrial enzymes are X-links, if the male is suffering, that male fetus is suffering from these abnormalities, there is defective fatty acid oxidation, and this transmission of unoxidized long chain fatty acid will enter into the maternal circulation, which causes hepatic damage. The commonly acute fatty liver of pregnancy presents in the late pregnancy, like 30th to 38th week of gestation. But there are some cases which reported as it can present as early as 18 weeks of gestation, and it can present even after 4 days after the delivery. The clinical picture mimics HELP syndrome like nausea, vomiting, anorexia, abdominal pain, jaundice, and encephalopathy, coagulopathy, and hypoglycemia. Hypertension present in most of the cases, and proteinuria also present in up to 10 to 15% of the cases of acute fatty liver of pregnancy. When compared to the HELP, the acute kidney injury and multi-organ failure and morbidity will be high in acute fatty liver of pregnancy compared to the HELP syndrome and preeclampsia and severe eclampsia. So the lab parameters are elevated bilirubin, transaminase levels, and elevated PT with INR, and increased urate, ammonia, creatinine, and WBC, and only levels of fibrinogen. The low levels of fibrogen, which gives a clinching diagnosis of acute fatty liver of pregnancy compared to the HELP syndrome. In acute fatty liver of pregnancy, fibrinogen levels of 300 milligrams per deciliter is the confirmatory diagnosis of acute fatty liver of pregnancy compared to the HELP, where the levels will be high. Coming to the management of acute fatty liver of pregnancy, prompt delivery regardless of the gestational age. Once there is after the delivery, there will be recovery of the hepatic function in general. The recovery of the LFT will take 7 to 10 days, whereas coagulation abnormalities improves within 24 to 48 hours after the delivery. The major causes of mortality and morbidity are the hemorrhage and liver failure and acute kidney injury. Next slide, please. And then is the HELP syndrome. This has been covered by the previous speakers. So this, so the incidence of HELP is more when compared to the TMAs and acute fatty liver of pregnancies. So the diagnosis is based on the tennis classification, which includes hemolysis of 2 of the following, like peripheral smear suggestive of hemolysis and elevated indirect bilirubin more than 1.2 and LEH more than 2 times of the normal and low heptoglobin, and this anemia which is unrelated to the blood loss. The presence of any 2 of these criteria will help in the diagnosis of HELP syndrome. And low platelet count less than 1 lakh. The thrombocytopenia is moderate in HELP syndromes compared to the DIC. The outcome of HELP syndrome will be most of the times will be good, and death due to severe complications like abruption, hemorrhage, and subcapsular liver hematomas. The risk of recurrence in the future pregnancies has found in most of the studies, and there is also increased risk of gestational hypertension and preeclampsia in subsequent pregnancies. So when we have to, what is the timing of the delivery? If the person is having severe renal failure and pulmonary edema, first we have to stabilize and then we have to perform the delivery. If it is more than 34 weeks of gestation, we can safely deliver. But if there is less than 34 weeks of gestation, we have to give betamethasone to accelerate the fetal lung maturity. This management part has been covered by previous speakers. So, in final, what are the parameters which helps in the diagnosis of specific entities? Like preeclampsia, the incidence is high when compared to the other entities like TTP, complement mediated TMAs or DIC. And the time of occurrence, Preeclampsia, HELP syndromes, and preeclampsia, HELP syndromes, and complement-mediated TMAs occur in the late gestational age or postpartum. Complement-mediated TMA typically occurs in the postpartum period. TTP can occur throughout the gestation, like immune-mediated TTP, whereas hereditary TTP occur in the late gestational age. Whereas hemorrhage and leak and sepsis, they can occur either early in the pregnancy followed by any abortions or following delivery with puerperal sepsis. So what are the vital signs which helps, gives a previous slide please. Presence of neurological abnormalities gives you a clue you are dealing with a thrombotic TTP, and neurological features also present in HELP syndrome and severe preeclampsia. The neurological manifestations will be same in both TTP and preeclampsia related, like headache, visual abnormalities, photomas, stress, and microangiopathic hemolysis, presence of cystocytes present in TTPs, preeclampsias, and complement mediated also. Next slide, please. The kidney injury, the renal failure is more severe in complement mediated TMAs when compared to the preeclampsia, HELP, and TTPs. The renal failure will be severe in acute fatty liver of pregnancy also, compared to this HELP syndromes. The liver function tests will be more than 2 times elevated in HELP syndromes, whereas 3 to 5 times elevated in acute fatty liver of pregnancy. Whereas LFT will be normal in TTPs and other complement-mediated TMAs. So what is the typical course following delivery? Preeclampsia, HELP syndromes will improve after the delivery, whereas TTP and complement-mediated TMAs have no role in the outcome. Their course won't be modified by the delivery. There is specific. What is the specific treatment? The delivery of the infant following delivery within 2 to 3 days, the features of HELP syndrome improves, whereas after delivery, if there is still new onset of acute kidney injury or there is a progression of renal injury, we have to suspect complement-mediated TMAs. TTPs also, the course won't get changed with the delivery. So the role of delivery as a part of management is present only in acute fatty liver of pregnancy and HELP syndrome, where delivery improves the outcome of the both mother and the fetus depending on the gestational age. Whereas in complement-mediated TMAs and TTPs, the role of delivery is only as per the off-stick indications, but not based on the clinical picture of either microangiopathic hemolytic anemia or the renal failure. So, specific managements, if it is a complement-mediated thrombotic microangiopathies, we have to give either plasma infusions or plasma exchange if the anti-complement therapy is not available. And plasma exchange has to be given in TTPs, and hemorrhage, leak, and sepsis has to be treated based on the clinical scenario with the antibiotics and the supportive treatment. Thank you. Thanks for the organizing committee for giving me this opportunity, and sorry for the inconvenience which was caused in slide sharing, but I don't know the reason what happened in the slide sharing. Thank you. Thank you very much.
Thank you, madam. My deepest apologies for discrepancy in slide sharing. And that was a good session. And over to you, Jikki, madam.
Congratulations, Dr. Sarat Jyosna. Despite a few hiccups in the sharing of the slides, that was a very good presentation. And you had covered the aspects which has been left out by the previous speakers, and that's very good. But you could have covered a little more on the plasma exchange aspect. That's what I expected here. Anyway, congratulations to you, Dr. Sarat. And over to the others.
I have completed my presentation. Thank you. Over to you, Saivani.
Okay. I request all the participants, please share any questions are there in the chat
Saivani,
box.
over to you.
Yeah, madam. I request all the participants to share any questions in the chat box. Bashir, please display the chat box.
Saivani, over to you.
Am I audible, madam?
Yes,
Yeah,
audible.
yeah. You are
Yeah.
audible very much.
Yeah. So, Bashir, please display the chart box.
One question is there in chat box.
Yeah. How beneficial is HDF compared to conventional HD in pregnancy CKD on maintenance hemodialysis?
Saivani,
Madam, tell me, madam, Sharad Joshna, madam, is there any problem?
Jyotsna, can you hear any of us? I think you are not in this. Jyotsna, can you hear us? I think she cannot hear you.
Okay.
Better call her up and tell. So I think she's confused now. I think she's.
Okay, madam, I'll speak to her.
I don't know. I'm off the screen.
Even I am not.
Saivani,
Oh yeah.
Shailja, madam, will you call Sharad Joshna, madam, and let her know?
Okay, okay. No problem.
So the only
hello.
The main problem is
లేదు అది ప్రెజెంటేషన్ అయిపోయింది నాకు అసలు ఏం వినిపించట్లేదు.
I'm not able to see the other participants at all. I am back on the main screen of my
లేదు
system.
నన్ను అన్మ్యూట్ ఏం చేయలేదు మేడం.
Bashir, are you there? Bashir?
Yes, ma'am. Yes, ma'am.
Please share the screen.
Sharad Jyotsna has to unshare her screen.
Okay. Anuradha, madam, is it okay now?
Yeah, at least I can see. Are you able to hear me?
Yeah, madam.
Yeah, madam. Yes.
Yes, ma'am.
So the only question in the chat box was how beneficial is HDF compared
Hello?
to conventional HD in pregnancy CKD on maintenance hemodialysis?
Dr.
I would like to remind you
Dr.
that
Ratna Prabha?
Can you take that question?
Ratna Prabha?
Yes, ma'am. I can take that question.
Yeah.
Actually, intensive hemodialysis is one thing which has to be practiced in
Can you
pregnancy.
hear me? Over to you, Saivani.
Intensive hemodialysis for the benefit of the fetal development, for promoting appropriate fetal development, we have to dialyze aggressively. The data is limited, but when and where possible, if it is available, HDF is definitely superior to conventional HD.
Over to you, Saivani.
Madam, we are hearing you, madam.
So the idea is to maintain
Hello?
a blood urea less than 40.
వినిపించట్లేదు మేడం.
And this data, what I am saying, is from the anecdotal reports only. There are no control trials.
నాకు వినిపించట్లేదు మేడం, అసలు అంతా మ్యూట్ అయిపోయింది. ఆ బషీర్ ఏమైనా అడ్జస్ట్ చేయాలేమో మేడం, నాకు అసలు వినిపించట్లేదు ఏమి. నేనేమి చేంజ్ చేయలేదు అసలు.
But
Shailja madam, request Sharad Joshna madam to mute herself then.
హలో,
I think she should mute. Sharad Jyotsna to mute.
I will speak to her now.
Yeah.
మేడం.
Yes, ma'am.
Ratna
Yes, ma'am.
Prabha, please carry.
Yeah, ma'am. At the present.
Oh.
Can't hear your voice. Dr. Ratna Prabha, you are muted.
So, am I audible to everybody?
Yeah.
Yes.
So the present topic is acute kidney injury, but however, the question is being on ESRD woman who got to be pregnant while she is on maintenance hemodialysis. And the question is about comparison between HDF versus conventional hemodialysis. Yes, intensive hemodialysis will always help because that will reduce the uremic environment, and which is good for the developing fetus. So the blood urea nitrogen should be less than 40 milligrams per DL. That is the ideal blood urea nitrogen cutoff. And if possible, you can intensify either by increasing the frequency daily dialysis or nocturnal daily dialysis, or else HDF, if possible, we can give. And the data is limited actually in the literature. But this data of intensive hemodialysis is beneficial rather than the regular hemodialysis is from the anecdotal reports available in the literature.
Okay, thank you.
Thank
Any
you.
questions from the audience? Please unmute yourself.
Ma'am, is eculizumab available in India, ma'am?
Yes.
Anyone have any experience about eculizumab in non-pregnant cases also?
You can get eculizumab Shailja in India. It's quite expensive, as we all know. But if you directly talk to the company people, it's available, you can get it. And there are some cases where it has been used, especially Medanta is using it, the pediatric unit of Medanta, Dr. Siddharth Sethi, Dr. Siddharth Sethi, and I think Dr. Vijay Kir also has used it. We have not used it, but we know how to get it. If you want the contact number, we'll share the contact number on the group.
And even I have an experience, madam. My colleague, medicine professor, his brother is has suffered from TMA, and he received 4 doses of eculizumab. After that, he became non-dialysis dependent, and the creatinine was maintained at 2.
Yeah, so eculizumab is quite good.
Eculizumab has to be continued, isn't it?
Yes.
Yes, ma'am. Yes,
so probably cost factor
might have stopped
preventing
him.
that. Yes.
So you have to keep on giving weekly infusions, 900 mg, 1200 mg, and
Yes,
you should
1200 mg.
assure,
Yes.
and you should assure that the patient is vaccinated for meningococcal vaccine prior to administration of eculizumab, because again, it's a complement inhibitor, and meningococcal infections become very common. The other thing is you can stop and start also, and it can be continued in pregnancy, as was discussed during the sessions very well. So it can be continued in pregnancy, and once the patient is okay and the levels are normal, you can stop it. And there are cases where there was a relapse after stopping eculizumab, and it was successfully restarted. So we, as madam pointed out, another madam said, it's quite costly, and if you have to give lifelong infusions, that's a problem, because you sometimes may not be able to correct the defect, the complement defect. So now the question remains, how long to continue it, having started it. So if the patient is in remission, clinical as well as serological remission, it can be stopped. You can follow up with titers and restart whenever there is a relapse.
But ideally, Manisha, it has to be continued, isn't it? What is the cost, by the way, if I can?
1 crore, I guess.
100 milligrams?
Each is 300.
1200 mg cost 1 crore?
I don't know.
10 lakhs and all odd, madam. 10 lakhs and odd. And for his all 5 to 6 sessions, it was around 1 crore, madam.
Yeah, same.
And then if you stop it and then again it has to be restarted, it is beyond most of the
reach of the people.
Reach of most of us.
Yes, ma'am. Yes, ma'am.
Yeah.
Madam, but there's one thing, because it's a second hit. You are born with a genetic defect, and a second hit. Sometimes it will be useful and rather prudent to prevent a second hit. Here, pregnancy has been a second hit. Likewise, drugs could be a second hit. So you need to avoid a second hit so that you can bring down the course of the eculizumab as well.
Yes, ma'am.
Yeah,
the triggering factors to be controlled.
Yeah, very well said, Jiki madam. See, only problem is we are able to diagnose the disease when it becomes manifest after a second hit. So once a second hit has occurred, that's why you can sometimes stop the infusion, because what happens is once the second hit gets corrected automatically, the patient goes into remission. Again,
Yes.
you may have a second date, but staying in India, avoiding infections is easier said than done. And counseling
Yes.
our patients not to go for a second pregnancy sometimes is even more difficult.
In fact, the other day there was an international ISN webinar on pregnancy in patients of CKD, and then we cannot say no in India to pregnancy, even if patients have CKD. In fact, that the girl who was being discussed, she came online and she said she's now back on dialysis. She had a transplant. The transplant failed. She had acute antibody-mediated rejection. Now she's on dialysis, but still she's happy she has a child. She has a 6-year-old child, and now she says, I need to now work around how to get my child to school, to various activities, but I'm happy I have a child. Patient is CKD. No, in UK or in developed countries, there are facilities that these patients who are on dialysis are taken care of. But we cannot apply the same to our population, because what happens if something happens to the mother? In our scenario, the child is left motherless, and I think that's a big
Tragedy.
That's a big problem. And so I know it was a very good discussion, nice to hear and nice to learn, but practically we need to know where we are and how we should use the available knowledge, depending on our situation. So
Anuradha, madam.
Yeah.
Madam, please continue. I'll talk later.
Yeah. I've done, Jiki. So.
Madam, you are talking about the patient who had CKD and she had a providential, fruitful pregnancy.
Yes.
And that happens very rarely only. But she had she was blessed with a child.
She was not in ESRD when she became pregnant, but post-pregnancy, her renal functions worsened.
Yes, sir. Okay.
She went into ESRD. She had a transplant. She had severe problem post-transplant. She had a transplant nephrectomy done and back on dialysis, but yet she's happy. She's an Indian, by the way, and she's happy that she has a 6-year-old child. So that is, they say, the importance of motherhood.
Yeah, sure.
Finally,
And
madam,
in fact,
as you said,
pregnancy and postpartum itself is a second life to every woman. With the discussion going on, it is very difficult to say how we all escaped having any complication during pregnancy.
Yeah, yes, ma'am. So just to add to your point, many of the postgraduates, they said, good thing we finished the pregnancy before joining nephrology. At least I thought like that, because it was so scary after seeing.
Manisha, just to, yesterday I was talking to one of our fellow nephrologists. He has become a grandfather now, and his grandchild was premature because daughter developed severe hypertension. She had proteinuria, and the proteinuria went so high, it was 12 grams. So imagine a nephrologist knowing the complications, his own daughter has such a big problem. So the child, they had to do an emergency C-section, and the child was only 1.7 kg, the newborn. But now, and this is none other than our Krishnan, Manisha, by the way.
Oh,
Jiki. So Krishnan has become a grandfather, but he had to go through this so much of mental stress when Pooja had severe accelerated hypertension. BP would not come down in spite of using 3 or 4 drugs, labetalol infusions continuously, and then she developed proteinuria, massive proteinuria of more than 10 grams. So, like,
actually, one of our nephrology, I think, colleagues' wife had Praki, and
yes. She's that nephrologist is from Apollo. He's a postgraduate.
Yes.
He has not yet got, and she now has a pachycortical necrosis. She's very, very sad. First child. So like you say, we all finished that. No, but I know it's a nightmare. Like you say, pregnancy is we don't know when problems will occur and how to prevent.
So
And
probably
we are
only thing is,
fortunate,
some of the
and
things
thank
are
God for all
unpreventable
that, ma'am.
also. The preeclampsia, you cannot prevent it, because in developed countries also preeclampsia is still there. But in India, what we can work towards is having a booked pregnancy, because many of the times the pregnant ladies land up, as you know, in nephrology for the first time. So maybe directly from gynaec ward, and gynaec, they are just admitted a week before the delivery. So unbooked pregnancies is one what we can avoid. Other thing is infections, what we can avoid. And luckily now the infections are becoming at least less common because of legalization of abortions and better management peripartum as well. Now, other thing what we'll have to worry in future is the age of pregnancy now moving up. Age of marriage is moving up, pregnancy is moving up. So again, the cause of prachi in the developed countries are soon going to become the leading causes in our country as well, assisted reproduction. I think we are disturbing the nature, and we are going to bear the brunt of that, I think.
Madam, I have one bitter experience of pregnancy, madam. Actually, she was referred at 5th month of pregnancy at creatinine of 2, and the biopsy differed at KIMS Hyderabad, madam. And she was having massive proteinuria, and family history of father was having hemodialysis and expired. So we go ahead with biopsy. It was IgA with 20 to 30% chronicity. Bitter to that, she had during 7th or 8th month, she had COVID, madam. And no gynecologist was interested to deliver her. And at Karnool Medical College, she got delivered, and she had delivered to a preterm baby. And after that, after 3 months, the AKI was progressed, and she went into CKD, and she was not on follow-up, madam, and she succumbed to the disease. And after she was having pulmonary edema, they called me up, and they were on the way bringing to the hospital. She expired, madam. Because of that loss to follow-up and all those things, we'll miss the patient. So better to avoid the pregnancy or terminate the pregnancy. That was my bitter experience with that girl, madam, who is young, with creatinine of 2 with massive proteinuria.
You are right, Saivani. Here, the maternal complications should take over the expected fetal complications.
Yes.
You have to somehow save the mother in such situations.
And the baby was now motherless, and she is preterm.
So here the maternal, I mean, the mother should be saved first, yes. Should be our motto here.
That may be my wrong thinking. Because she already crossed 5th month, termination might cause any bad thing to the mother. So I thought of continuing the pregnancy, but that was my bitter experience. She was kept on steroids.
Even if you continue pregnancy, Saivani, it should be under very, very close observation.
Yeah, madam. But that time that she was having COVID, so I couldn't request the obstetrician. Please, madam, go ahead like that. So we have to refer her to GGH Karnool. There, what happened, I don't know. But preterm delivery was there at 7th month by LSCS. And after that also, they are not with the regular follow-up, madam. That's what the issue. Because if they are under regular follow-up, we used to initiate hemodialysis and all, but they are not under regular follow-up. After everything is over, they have called me up, madam, now she is having high SOB, we are bringing her to the hospital, like that.
So the problem is ki even if you may advise termination, but would the family be willing? Many of the times the in-laws and the husband, they may not listen to it. I mean, in India.
Yes, madam. Yes, madam. The baby is very important for them.
Yeah, baby is very important.
And otherwise, they will go for second marriage.
Yeah. So that's what. So let them go for second marriage. Females are also important. Leave it, divorce, and be independent, be healthy, be happy. That's it. I mean, that concept should come. See, many of our SLE patients, they don't want to. Madam is smiling, I know. See, many of the SLE patients. No, ma'am, please let me
let me share an experience with Manisha. Let me, one nephrotic FSGS. That husband came to my room and he said, so I said, Dekho, you are having so much proteinuria, you have hypoalbuminemia, and you have some renal dysfunction, and you want somehow you want to become pregnant. Then she says, मुझे कुछ भी होने दो, परवाह नहीं, लेकिन मेरे husband को एक बच्चा चाहिए.
Yes, madam.
Then the husband came to my room and he said, मैं इसको कितने दिन ऐसा support करते रहूंगा? I will support her, but I will get remarried. I said, see, don't discuss your social problems in my room. As it is bad enough that you're doing this to your wife. Because she has an illness, you're abandoning her, you want to go for another marriage. And मैं उसको छोड़ दे, मैं दूसरा शादी कर लेता हूँ. But did I say I will not support her? I will support her.
फिर उसके बाद आप क्या करें मैडम? नेक्स्ट व्हाट डिड यू डू? यू टेल मी. आपने ना उसको वापस बुलाना था. You should have called that female, you should have told the husband, go, I'll talk to her and tell that before he divorces you, you divorce him. And this is what he said. You know, madam, I think we should.
Manisha, वो क्या बोली? मुझे कुछ भी होने दो, but I want that my husband should be happy. My husband should have a baby.
अब समझा तो देना. After that, whatever she does is her headache or her choice. But अपनी तरफ से ये बोलना कि देखो तुम भी human being है. Everybody is important in this world, male or female. और आप खुद के लिए मेरा ये suggestion है. I'm just telling you. I'm not forcing you. But आप ये भी सोचो बोल के कई बार sometimes they understand, ma'am. SLE patients देखो, they hide the SLE. They don't take medicines. आके बोलते हैं अपने पास. You probably have a longer experience than what I have.
I had another experience. I had another experience of a nephrotic getting married, right? When the day before her nikah, one day before, she came to the hospital with severe nephrotic state, with a serum albumin of 1. Her marriage is next day, but they don't want the marriage to be postponed. Neither the husband to know about it. They're telling me, आज कुछ तो भी दे दो so that कल शादी होना. So
उसका दे देना था ऊपर से नीचे का और क्या करते?
मैं क्या करी? मैं एक steroid दे के भेजी. I said it's your luck. But look at that. Look at her luck. She got married. Her husband knew about it, but mother-in-law even till date doesn't know about it. Husband is a very nice guy. She's lucky in that. He supported her. And then now she's a mother of 2 kids. It was minimal change. So obviously she went into remission. But I'm saying, as doctors, we face such unusual circumstances where we don't know what to do. I said, कल शादी है और आज you want me to make her all right? How is it possible? But in India,
ma'am,
pregnancy is important. Having a child is important. Come what may to the mother, the men are least bothered about it. But
times are changing, ma'am. I'm happy that times are changing.
Manisha is great.
Generation में है, हम middle generation में है और हमारे future generation. आजकल, I think, देखो, we should adjust. Females should adjust, compromise everything, but not at the cost of their happiness. वो भी करना. It is a fine balance, I think.
That's exactly, so, Manisha. No, I'm also. I mean, you are a great advocate of women's right. I appreciate you for that. But I follow a slightly, what should I say? Balanced view. Balanced view.
I'm not that. मैं ये बोलूँ कि if such situations, if it becomes intolerable, only thing what I wanted to say was Praki ka only thing is what we are not doing is long-term follow-ups we are not doing. वो एक करना है. And other thing what we have to do is see Praki ke investigations में what we are missing because of the cost or whatever the complement
genetic testing.
Genetic testing, it's better to get it done for all because Praki, especially with cortical necrosis and all that, many times the papers have said, like one of the papers,
especially when you have severe hypertension, just get a genetic workup done.
And Adam TS also that TTP, it occurs in 3rd trimester. Generally, atypical HUS is postpartum most of the times, but nothing in medicine is 100%. But 3rd trimester, if you have that thrombocytopenia and all, generally you won't have these TTP patients in renal ward. They'll go to a neuro ward or they'll be in medicine ward. So we should be smart enough to pick them up. So thrombocytopenia, pregnancy, 3rd trimester, with or without neurological signs.
Not just genetic testings, Manisha. Adam TS
So that's what
is available.
So what happens is, ma'am, most of the times in ICUs, whenever thrombocytopenia is there, plasmapheresis is started. Before that is done, collect a sample. Otherwise, you will never be able to demonstrate
that
it.
is what recently, I was not the treating doctor. I happened to go to ICU, suspected TTP. Then they wanted to do plasmapheresis. It was 5:30 in the evening. I called the lab. I said, can you send this for Adam TS13 level? And so he said, madam, आज का तो flight तो हो गया. I said, कुछ भी करो बाबा, हम लोग blood draw करके रखते. At least I was not the primary, but I drew the blood and I made sure that it was sent, and Adam TS13 levels were extremely low. So,
and the next thing is post-pregnancy, the atypical HUS also, like we are sending for genetic analysis many of the times, and NGS is the method they're employing, but that multiplex ligation probe assay, that also we should do, because some of the copy number variations and all are missed by the NGS. So I think the whole thing should be done. Then we'll pick up more cases. Otherwise,
everything, Manisha, cost is the factor.
Yeah, that's true. That's
true. In fact, at this stage of my life, is Jiki still there? Okay, Jiki, that's for you also. That's for you also. So at this stage of my career, I am now into, in fact, there are, for recent 1 or 2 patients, I have paid for the genetic testing. I said, it's okay, because diagnosis was important. And then we got an autosomal recessive variant of Alport's. That was a case I said, it's okay, I can do some charity now. You know, I don't need to really earn money, and what will I do? So, but cost is a major issue. Many people cannot afford. If in Osmania somehow you're able to send Manisha, that's good. But
like you, madam, individual charity, to my probably at your age I will do. Abhi I'm trying to make the system work and make it free for the patient. So patients ko koshish to kare, madam. Like having projects or having an association, fighting with everyone in the administration.
Which you are able to do. But for people who are in private, totally, Manisha, and if the patients can't afford, it becomes really difficult to send.
Yeah, for us also it's difficult. But others, we are trying to, have work through some NGOs and all those things. That's it.
Okay.
I would like to add
there was another question, madam. What are the reasons for high rash, though there is volume expansion in pregnancy? Reason for this paradox. Sindhu, will you take up the question?
What is the question, ma?
What are the reasons for high RAS, renin-angiotensin system, though there is volume expansion? Reason for this paradox. Sindhu? Sindhu Chagante, are you there? Pavani, madam, will you take up this question?
Okay, if nobody is taking up this question, I have a question. And
can I
would
answer
like to
that
comment,
question, ma'am?
Okay, Ratna.
I would like to comment. Can you hear me, ma'am? Dr. Jiki speaking here.
Yes, madam.
I would like to comment that education of a female and going for a job and economic independence will give her the freedom for medical management. Because many a time, the female who is married one is dependent on her husband's family or the parents' family to support. And that's why they lose they don't come regularly for a follow-up or get the investigations done and all. So we have to look at the root cause is education of the females or all women, and go for a job and be economic independent will help them to take meaningful decisions also, and take care of their health and prevent complications arising out of certain illnesses like our renal disease. And also I would like to add that this time we have covered only pregnancy related AKI. But in the subsequent month, in the coming month, we would like to take up nephrotic syndrome, CKD, and post-vasculitis and post-transplant pregnancy management also as a
UTI and CKD.
Yes. Okay, and over to Pavani, who would like to answer the question that's been put up.
Ratna Prabha wants to answer, madam. Over to you, Ratna Prabha.
The reason for this paradox is there will be production of this renin-angiotensin, this other sources of production from decidua, from ovary as well. And there will be insensitivity to the RAS. That is the reason RAS goes higher. These are the two reasons proposed. And I would like to comment one thing on your experience, madam, which happened that IgA nephropathy, Dr. Saivani madam's experience. I think there is nothing to be feel guilty of, because preeclampsia itself is not an episodic disease. It may be a predictor of that the woman may go into CKD or some other renal problem in the future. So even if you have saved the mother, how that IgA eventually will turn out to be, we don't know. So preeclampsia, long-term follow-up.
What is my guiltiness is a preterm female child was born, and who will take care of
priority. Yeah, I understood.
After maternal death, who will take
but preeclampsia is not an episodic or pregnancy related. It's a long-term issue, and long-term follow-ups, they may be developing future CKD. Even the babies also are having more chances of developing hypertension and CKDs. The papers are coming up like that nowadays.
Her biopsy was already having chronicity, 30% IgA nephropathy. And even then we have continued, though as we thought the creatinine was 2. And worsening thing is presence of COVID and preterm delivery, all those things.
Just what I want to say is, it is preeclampsia may be an indicator that eventually they may go into CKD.
CKD, And her father also died because of CKD. So it's a familial disease, and she was having
genetic predisposition.
she was having genetic predisposition.
Long-term follow-up studies for these preeclamptic women, how many are finally going into CKD, hypertension, and what are their outcomes, we needs to come up. That's what I think.
Follow up with Praki, that Manisha madam should do. She had 150 patients. We have to ask those 150 patients what happened to them, how much is the creatinine and proteinuria. If we can allot one postgraduate for those 150 patients, we can get that follow up data.
Even the outcome of the baby who born out of preeclampsia is different.
Yes, that is a huge exercise, and that's what we are trying to do. See, that's why the importance of registries, and soon you will get a mail about like how we are trying to maintain registries in WIN, long-term registries, because following up the patients, Saivani, cohort studies are a big issue. Phone numbers change, patients migrate. So we are going out of our mind trying to contact those patients.
And also expired patients, madam, will yell like anything, madam, because we have spent like this. You have done like this.
So whatever longitudinal cohort studies in India are easier said than done. We have to listen to all those things. Many of the times the numbers are not there. So now it's better to take 2 to 3 numbers if you are trying to do a cohort study. So all those things are very important.
We have experience during collection of data for this hemabsorption system, madam, hemoperfusion during COVID. Whenever we have called them, they will yell, madam, because you have spent 1 lakh rupees, but no outcome, like that. So we are afraid of calling them, and I have allotted all our PharmD students to call them, but they are asking, madam, no, we don't call them, madam, they are yelling me.
Saivani, Dr. Saivani, a PG cannot be allotted this longitudinal study.
PharmD students, madam.
Unit should take up the longitudinal study, cohort study, for looking for the long-term complications of preeclampsia or other complications that occur during pregnancy.
Yes, ma'am. Yes, ma'am. Are there any questions now?
No questions.
Then I request Dr. Shailaja madam for vote of thanks.
I would like to propose vote of thanks on behalf of WIN India AP chapter. First of all, I would like to thank Shantiram Medical College management for supporting this session. It was a very enlightening session covering all topics in and out of renal manifestations in pregnancy. I would like to thank all the speakers for their lucid and informative talks. And I would like to thank all the moderators who are pioneers in our field with vast experience and made these sessions really interesting. I would like to thank the audience for their active participation. Once again, thank you all for your valuable presence on this Sunday morning. Wishing you all happy Sunday. Thank you all.
Thank you, madam. We'll come up with, after 1 month with the next session covering UTI, CKD, SLE, and all other disorders in pregnancy. Thank you.
Ma'am, we could not hear you, ma'am. Anuradha,
We could not hear, ma'am.
Sorry.
Anuradha, ma'am, we could not.
Yeah. I've unmuted now. Okay. Hearty congratulations, Saivani and the entire team.